81st International and 3rd National Conference of Speech and Hearing Association of Nepal, Shan. To further carry out our audiology and otology related events, focusing on the theme early intervention and identification, I would like to call upon our guest speech by Mr. Jyotilal Das to present his topic, neonatal hearing screening and importance of premature hearing evaluation. And to chair his session, I'd like to request Professor Dr. Sandeep M. and Mr. Anil Kumar Adhikari. Please take your seat.
So to start with, we have our guest speaker, Mr. Jyotilal Das, who is audiologist and speech language pathologist in Rainbow Children Hospital, Banjara Hills, Hyderabad. He has been actively involved in newborn hearing screening, and he's also pursued a lot of work in research, and he has been attending several national and international seminars, workshops, conferences, and he has got more than 10 years of experience in the field. So we are eager to listen to you on neonatal hearing screening and importance of premature hearing evaluation. And I also welcome my colleague, Mr. Anil Adhikari, for this.
Thank you for the introduction, sir. Myself, Jyotilal Das from Rainbow Children Hospital. I will be presenting on neonatal hearing screening and importance of premature hearing evaluation. So yesterday, as Dr. Milan ma'am said regarding prevalence, so in this I will just add on the futuristic. So here they are saying WHO at 2050 we will be having 700 million population affected with disabled hearing loss. And according to Disease Control of Prevention in USA, in 2019, 1.7 per 1,000 babies were reported with hearing loss while screening. So neonatal screening, definitely a neonat means baby is 28 days. In this, there are two models which mostly preferred. One is early hearing detection and intervention, and one is infant hearing screening committee. This model has been updated and revised and has requirement and also necessity as the development happens in the field. So now it is suggesting like at 2 months your diagnosis should be completions and 3 month intervention starts. And JCIH still suggests the same, but yes, it gives a time period of 3 to 6 months, mostly for the infants. Premature is any child which is below 37 weeks. So a typical pregnancy is of 40 weeks, and in that too there are late preterms, moderately preterms, very preterm, and extremely preterms. In premature babies, mostly these are the causes and high risk factor what we need to see when you are screening and all. There are certain factors which are throughout the periods and all others. When you are in a hospital setup or any setup where the child is in medical clearance, then we can go for the premature hearing screening. There we should see the red flags, high risk registers babies, proper follow-up and tracking should happen. The detailed audiological assessment should be followed up for the premature babies. Once hearing loss is confirmed, we can go for the counseling and interventions plans. Also, developmental pediatricians too plays a major role when we are going through the development of the child. This is already we have discussed so much about it yesterday. This is the guideline which was given by JCIH. And this is the older one. Hope it is visible. 1 month, 3 month and 6 month plans. So 1 month we have to diagnose, screening should be over. In 2 months, in 3 months diagnostic evaluation should be over, and within 6 months of period we should complete the interventions part. And intervention mostly include hearing aid fittings, therapy enrollment, CI counseling and all. And this is what we follow in Rainbow Hospital mostly. Neonatal hearing screening for healthy babies, we do after 48 hours, pass, refer and fail criteria. If pass, then we do counseling and awareness at least, so that we do not miss ASD or in future any complication. And here, if it is fail, we do after 15 days re-screen and then go for the detailed audiological evaluation, either it is pass or fail, so that we do not miss any ANSD challenges in newborn hearing screening and premature hearing screening. Audiologists which face day to day, lack of awareness among people, lack of willingness of people, difficulty in getting newborn hearing screen protocol permissions from all the hospital managements, poor ambience with high noise floor, lack of team coordinations. Here the team coordinations can be anyone among management, doctors and other colleague members. Psychological issues can be there with when you go for the hearing screening. Some patients do not allow or hesitate, so their belief, cultural, social, emotional factor can be the role. Behavioral, sometimes when you go for the screening, child does not cooperate, child keep crying, or it might be their feeding time, or it may be like a hunger cry or insufficient feed. So some of the other thing is happening. Medical complication and LAMA discharge can also be one major factor which day to day audiology faces for when they go for the newborn hearing screening. What will be the impact if we don't do hearing screening and we miss the child with hearing loss? So it can affect your communication and speech, cognition, education and unemployment can be there, social isolation, loneliness and stigma.
They also know what is the child's immediate requirement. Is it that the child's sibling's birthday is coming up, or the child needs to be able to say some functional vocabulary? What is actually the child's immediate requirement? And they are the ones who, based on what we tell them, they will know what they are comfortable with and what the child is comfortable with. And after they have gained that faith on you, sometimes they might be able to take the leap of faith and go that extra mile so that they can do wonders for themselves as well as their own child. So now let's look at what is the role of professionals when it comes to dealing with children with CI. First and foremost, we have to enable shared responsibility along with the families. We need to provide ethical services which are at par with the best current trends in rehabilitation, because it is an ever evolving process. And here I would like to reiterate, not just try to do things that are established in the field from a long time, but also look into what new has come and how it can suit and cater to the needs of the child and the family. Thirdly, tailor-make and individualize the family-centered intervention plan that includes the family's needs, is realistic for them to carry out, is flexible, engaging, and worth every minute that the parent and the child spends with you. Yes, they do come to us maybe twice a week, thrice a week, or sometimes once a week for session, but still every minute that they spend with us, that really counts, and that time we must be providing them with some services that is really meaningful and engaging for them. Fourthly, we should collaborate with the family as well as other professionals. These families might be going to other professionals for seeking services for some of the other additional disorders that the child could have. So we have to be the connecting bridge between everyone. Say for example, the ENT surgeon, the audiologist, we are the SLPs, let's say if they are taking some facilities from the psychologist, from the school teacher, from the PT, OT and so on. Continuous sharing of information and updates in a respectful and supportive manner with them, and provide written notes, because for us we learn these things maybe in 4 years or 6 years or even more, but for them it is new for them. So when we tell them all the information like blah 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 blah, many a times they might say that yes, we have understood, but then they forget. So if you give them something written, they will have a document to refer back if they really need to know what they want. What strategies they must be employing while they are trying to teach the child the names of 5 fruits or concepts around fruits. So we did a possible gap analysis to try to find out if there could be some possible gaps between the family's perceptions and the professional's perceptions regarding the support that the families receive or what the professional provide. This is just a preliminary attempt. This is not a research, not a paper, or not anything formal. It was just analysis of data that we received from feedback forms from the families and professionals. So we have information from 1,000 families with cochlear implant recipients and 30 habilitation professionals who have more than 5 years of experience of working with children with hearing loss. So the first question that we asked the professionals was, in which stage do you actively involve the parents? And like you can see, about 75% of them, they did say that they did involve the parents actively in initial consultation. Then came about some 60 something percentage for progress tracking. About 55% of them did include them in assessment. And then goal setting was the lowest rank. Like the professionals were setting goals and they said that we are involving the parents actively even while we are setting goals. We asked the same question to parents as to how do you, we again asked the therapist, how do you involve the parents actively in each stage that you said? And then these are the voices of the habilitation professionals. They said that we try to find out from the parents what the child does at home. We use parental questionnaire. We have a common Google sheet between the therapist and the parent. We check our concerns with the goals. We educate them about facts. We counsel the parents. We take inputs about the child. We use them as models in therapy. We provide them with expectation questionnaire and try to match the expectations realistically, and then we use the parents for demonstration of activity. Then we ask the same question to the parents, how are you involved in your child's habilitation process? And these are the voices of the families of children with CI. So most of them said that they were like an assistant to the therapist. They were asked if they are practicing at home or not. The therapist took information about the child. The parents were merely made to just observe the sessions. They were made to correct the child's behavior. They were asked whether the child is doing at home or not. They were made to teach some vocabulary, and they were asked what the child needs in school. Then we also asked the parents what do they exactly want from the therapist. So the previous slide was holistically. It could be from the audiologist or from the management team or from anyone, but pertaining to the therapist, what exactly do they want? And then you can see most of them wanted to know from the therapist how to be therapist at home, and then how to do speech therapy at home. As in, they wanted to be their child's therapist at home, weaning away from the fact that they are parents or they are caregivers and they have to be that. Along with that, they wanted to know things like how to make my child sit, when will my child talk, when will my child speak more sentences, and so on. So it's time to go back. Yeah. So it's time for us to think. Parents have certain sets of expectations from the child, and they do have certain sets of expectations from the therapist. But when it comes to expecting from the child and expecting from the therapist, is there a match or there is a mismatch? I can see a clear mismatch, but I think it's time for us to think back, sit and think back as to what exactly they are expecting from both.
Now, please allow me to welcome our next guest speaker, Professor Dr. Sandeep M., to highlight on the topic recording ABRs, challenges and misconceptions. To chair his session, I would like to request founding president and patron of the Shan, Mr. S.L. Kern, and Professor Dr. Dipendra Shrestha, president of Society of Otolaryngologists, former HOD of ENT HNS Beer Hospital. Please chair the session.
I'm very thankful to organizing committee for giving me this opportunity. I'm very privileged and honored to introduce our eminent speaker, Professor of Audiology, Dr. Sandeep M., He is from All India Institute of Speech and Hearing, and his PhD, and he has 20 years of experience, including teaching experience. He has served as editor of American Journal of Audiology for the special issue on 15th ISKCON, and he has also served as associate managing editor of Journal of All India Institute of Speech and Hearing. I request Dr. Sandeep to proceed.
First of all, thank you, the organizers, for having given me an opportunity to share my little experience with electrophysiology. I've been teaching electrophysiology for probably past 8 to 10 years, and so during my practicals, there are a few things that I have realized with respect to the basics of electrophysiology, which I'm going to share in the next 20 to 25 minutes. But one thing that I want to say is, it's a very huge topic. This is something that we can go on talking for about 8 to 10 hours on recording ABRs, challenges and misconceptions. So I should say that this is very challenging for me to present this entire thing in the next 25 minutes. And on a lighter note, I should say, among the organizers, whoever thought that this can be taught for 25 minutes, they had a misconception. Okay, so I'm going to cover my talk in two broad headings. One is misconceptions in while recording auditory brainstem responses, and probably the interpretation and inferences being drawn from the auditory brainstem responses. And other one is with respect to the challenges in recording auditory brainstem responses. So there are many misconceptions. I'm going to cover the top 10. This is a rank list that I have made myself. There is no standard rank list like this. And this is totally based on my experience that I am going to tell you. So we all know that auditory brainstem responses have got two broad applications. One is with respect to its use in hearing threshold estimation. Other one is in terms of site of lesion testing, right? So we know that, on a day in and day out, we are using auditory brainstem responses for hearing threshold estimation, and it gives us a very good estimate of the hearing thresholds. And in every difficult to test population, be it a neonate, or be it a young child, or be it a child with different kind of associated conditions like autism, mental retardation, cerebral palsy, wherever we don't get reliable responses, or be it a case of malingering, wherever we don't get reliable responses, we do go for auditory brainstem responses. And it has got a very good agreement with behavioral thresholds, somewhere between 5 to 20 dB, depending upon whether it's a conductive hearing loss or whether it's a cochlear hearing loss. So if it's a cochlear hearing loss, generally the agreement is about 5 dB. If it's a conductive hearing loss, it can go up to 15 to 20 decibels. Now, having said that, I always say that it is not a test of hearing sensitivity. This is well known. It is not that I am saying this, this is well known. It gives a very good estimate of the behavioral thresholds, but it is not a test of hearing sensitivity. Why do we say that? Because if you take, for example, auditory neuropathy spectrum disorder can actually have normal or near normal hearing sensitivity, yet auditory brainstem responses are going to be absent. Or if you take a cortical lesion or any lesion beyond the pons, anywhere between midbrain or thalamic region or beyond that, what is likely to happen is one can actually have hearing loss of up to severe to profound, and you can still tend to have normal auditory brainstem responses up to 30 decibels and 20 decibels. It gives a very good estimate to us. It has got a good agreement with behavioral thresholds, but it is not a test of hearing sensitivity. So we should not have that kind of a misconception. Now coming to the second application, that is the identification of the lesions. We know that auditory brainstem responses are capable of detecting both the space occupying lesions as well as the diffuse lesions. And I want to narrate that story with 2-3 case examples. For example, this is a case that we saw about 3 weeks ago, and you can actually see that the right-sided ABR is fantastic. The responses are present with normal latencies, normal interpake intervals, whereas on the left, you see that we are able to see only the first peak of ABR, and later peaks are not present except the fifth peak. So fifth peak is again of delayed latency. This is a classical case of acoustic neuroma. So the moment we saw these auditory brainstem responses, we knew that it is acoustic neuroma. Just for confirmation, what we did was we sent this case for MRI. And unfortunately, to my surprise, what happened was MRI results came long. Okay, so what we did was we looked at the MRI image again, and what we found was on the left side there was a clear-cut acoustic neuroma. What I wanted to highlight here is the confidence that ABR results can give as an audiologist for us. So in spite of MRI coming normal, we were confident that it is an acoustic neuroma, and when we cross-verified it, we found in the MRI that there was an acoustic neuroma of up to 8 mm. This is what we call as contralateral effect of auditory brainstem responses. You can actually see that in the presence of such large tumors, you get to see there is a prolonged third to fifth interval and also prolonged 1 to 5th interval, which again tells you not just about the side of the tumor, it also tells you about the size of the tumor. So if the size of the tumor is large, it can distend the brainstem, and you get to see the effects of that on the opposite side's ABR. I'm not talking about the contralateral recording of the ABR, I'm talking about the ABR on the contralateral ear. The ipsilateral recording of the opposite ear will show abnormality, and you will be able to understand that it's a large tumor.
And Devi and Madam Dr. BUDHANILKANTHA. And thank you, Ms. Pooja, for the wonderful speech. Now we'd like to welcome Dr. Wasim Ahmed and Sir Mr. Kaviraj Khanal for chairing our upcoming session. Thank you, sir, for chairing this session. So I would like to hand over the mic to our chairpersons and to introduce our upcoming speaker, Ms. Shabnam Rafi.
The privilege to invite Madam Shabnam Fatima Rafi to take the podium. So, Madam Shabnam Fatima Rafi, she has trained more than 250 plus professionals and 1000 plus students since 2014 on concepts related to rehabilitation, specifically in auditory development in pediatric and adult CA recipients. Her current area of interest is rehabilitation of adults with hearing implants, and as part of her role, she supports professionals working with adult hearing impairment recipients in India. She is currently the manager and clinical support rehabilitation of MEDAL India. And I hand over the mic to you. Further.
Thank you so much. Good morning, everyone. First of all, I would like to thank the organizers for giving me this opportunity at ShanCon this year. What I'm trying to be doing for the next few minutes with my presentation is to talk about what are the different outcome factors that are important when it comes to managing children with cochlear implants. So the idea here is we understand the outcomes, specifically in the context of Southeast Asia region, India, Nepal, Bangladesh, and how we have been applying that in our practice at MEDAL. Next slide. So at the outset, it's very, very important to understand one thing about cochlear implants. Cochlear implants is only providing access to hearing which is not earlier available to children with severe to profound hearing loss. Now what that means is that the intervention process doesn't stop with just the providing of cochlear implants like we all know, but it's kind of leading into the second step, which is the actual hardcore management of children with cochlear implants, which we do in session, and like what Pooja talked earlier, parents try to manage at home. So with that, the next slide please. So I spoke on the pre-conference about the different stages that we have in the listening outcomes. So I'll just briefly touch upon that. In the first 1 year, what we expect children with cochlear implants to develop is this awareness, discrimination, identification and comprehension skills in a very non-integrated fashion, like in the sense that something that the child might be able to do with or without the help of language, core language input or speech input. But it is the second year which is where the integration that is going to actually happen, wherein the memory aspect is going to play a very important role. Whatever the concepts the child has been taught in the first 1 year, the child is going to convert that as long-term memory items in the brain, and that is going to further fine-tune the way that the child is going to process whatever language related information that the child is going to be hearing. And in the next stage, we expect that the child kind of develops a sense of tuning in, like what probably you guys are doing it right now. If there was some noise or someone making a lot of background movements, but you're still trying to focus on what I'm seeing, right? So you are pushing away the background and you're trying to focus on the speech here, and that will be possible in the second year. And then we have the auditory conversations, wherein the child is going to use their pragmatic skills, their social skills to carry out conversation in different contexts. And then finally, then we have the auditory speech loop, which is very important for the child to develop a good intelligible speech, and also for something skill like what I am doing right now. I am speaking, I am also simultaneously monitoring how I am speaking, and if there is some errors that I am producing, I am also simultaneously correcting it. And then finally we have the cognitive language, which is again something you guys are doing right now. You are of course listening to me, you're looking at the slides, but you're also thinking about what you're listening, okay, whether she's saying things right or wrong, does it make sense to my practice or not, and things like that. And what we are looking at is achieving that sweet spot where all these skills are kind of integrated in a very nice way for that particular child, and those skills are age appropriate for that child. So this is what we are looking into. Next slide please. Next slide. Yes. So I'm going to be talking about certain intrinsic and extrinsic factors that are specific to the Indian context. Next slide. We'll go one by one. Next slide. Yes, we'll start with the hearing age. So whenever we talk about hearing age, the idea is when has the child had an optimal access to the speech sound frequencies. Okay, so oftentimes I'm asked, okay, this child used hearing aids for like 3 months or 6 months. Should I be including this child, this age when I'm calculating the hearing age? So if you have solid information that says that by some miracle the child has had access to the speech sounds or the link sounds when the child had used hearing aids, yes, it's a good idea to kind of include it in the hearing aid calculation. But if that's not the case, you start calculating it from the day of switch on, which is when we expect that the child has had access to all the speech frequencies. Okay, and we are looking at all the 6 link sounds here specifically, even if it is the child is giving you an awareness kind of responses. The next thing is about developmental plasticity. This is one of the landmark studies done by Dr. Anu Sharma and her team, and she gave us wonderful information about how developmental plasticity helps in auditory based language learning. Certain group of children we can expect this to still happen till 4 years, and for certain lesser group of children till 6 years. And after that, there is a complete sharp decline. So when a child is implanted at say 7 years of age, if there is like 10 children in the group, probably 1 will be able to do it. Okay, whereas if we have the same 10 group of children in the age group of 0 to 18 months, all the 10 children we expect them to acquire this auditory based language learning. So this is something that's very important. But another thing that we have to remember is that next few slides has data on that. So what we did was we kind of compared the categories of auditory performance scale, which is a very popular tool in the fraternity in CI for its simplicity. It's a tool that is, you can just easily rate a child from 0 to 7, and everyone understands where the child is placed when it comes to how they are performing auditorily. Just to give you a snapshot, so a score of 5 means the child is able to really kind of follow conversations and pick up certain keywords from the conversations. Score of 6 means that the child is able to pick up more information from those conversations, and a score of 7 means the child is able to use telephone to converse in an auditory baseline, conversations.
Now, without any delay, I'd like to call our next guest speaker, Professor R. Ranjit. He is presenting on the topic Novel Methods in Hearing Restoration. I'd also like to request Professor Dr. Sanjay Kumar Munjal sir and Professor Dr. Rajsekhar sir to please chair the sessions.
Welcome to the next session, and the speaker would be Professor R. Ranjit, a good friend of mine. And Professor Ranjit has been working as a director of the Murph Institute of Speech and Hearing, and he is a pioneer in the field of electrically evoked auditory based and responsive, especially with respect to the ABI, and has a larger series of ABI under his belt.
Dr. Munjal said about it, because his relationship with him is different from my relationship. In fact, I have been Ranjit's UG examiner, PG examiner, right? And I have seen this boy grow from what he was to like what he is today. It's all self-made, okay, very, very sincere and dedicated, and he's lucky to have one of the best mentors, Dr. Mohan Kameshwar. Okay, but just having a mentor is not enough, but to be able to get the best out of the mentor. That is the quality which I think Ranjit has proved. And he has traveled wide, and I think I can tell you that he is one of the few authorities, audiologists, right, in the cochlear implant technology. He keeps himself abreast of the latest developments, and he has no hesitations in sharing it with the other people also. A lot of people keep it to themselves, but he is one who would like to part with it. So the more you give, the more you get. That's what they say. So that's about Ranjit. Right. One other thing I wanted to let you know is he is a chronic bachelor, right? And we are looking for a good bride for him. So maybe we'll get somebody from Nepal, Kathmandu. Okay. That's just on the lighter way. But as a professional in cochlear implant technology and AB and all that, he is an authority, right? I'm sure that you would love his lecture.
And, to add on to it, he was not just my examiner, he was my first examiner in UG and the last examiner in PG. So he knows me from what I don't know, and he knows me from what I know things. So he's been a great inspiration, not just for many of the audiologists, speech pathologists in the country. I think he's one of the best a person who you can inspire on. A person who started as an audiologist and has raised up to a level of a dean of a medical university is not easy, because very few people have achieved it. And that only says that his knowledge, his discipline, his command over his skills, and the respect that he has got from different fraternity. I think if at all somebody has to achieve some heights, you are the epitome that we need to achieve. And Sanjay Munjal is a great friend. Congratulate and thank the organizers of Shan for organizing one of the best conferences of this year. And I'm extremely delighted to be part of it. Thank you very much for the invitation. Now, before going into it, I wanted to highlight a few things. So, predominantly I work, as Rajsekhar sir mentioned, I work in the area of hearing implants. So, my job is to restore hearing for people with hearing disabilities. Now, we come across different types of hearing disorders. Now, what we've understood is, as we all know, Sandeep was extremely and was quite fascinated by his work, what he's been doing. And one of the most interesting things about audiology and electrophysiology or hearing science is the more and more you try to understand, less and less you understand about it. That's exactly what keeps us driving. Now, as we all know that hearing is one of the most sophisticated sense. It is the only sense that can be restored, even lost completely. If a child loses vision at birth completely, you can't restore vision. You can't restore any other lost sense except hearing. And today we have different processes or technologies available to restore hearing, like hearing aid, bone conduction hearing devices, your middle ear implants, cochlear implants, auditory brainstem implants, midbrain implants, and optogenetic implants. These are the different technologies which is available to restore hearing. I'm not going to highlight about the technology here. I think cochlear implant has been already spoken. Yesterday, the surgeon, what's his name, Ravindra was talking about cochlear implant. Chandrakant about brainstem bone conduction devices. So I'm not going to highlight anything about it. I'm going to focus on a very niche area of hearing restoration. So, the one is ski sloping hearing loss. Now these are the candidates who do not benefit much with the hearing aid, because you can't give a good amplification in high frequencies and you don't need any amplification in low frequencies. Now the question here is, how do we restore hearing for these kind of candidates? And quite often we see a lot of patients with ski sloping hearing losses. Right? Now if you look at the candidacy of cochlear implant, when we started in 1990s, I think Rajshekhar sir was one of the first audiologists to start cochlear implant program in the 1990s. So the indication was bilateral profound hearing loss. Today the indication for cochlear implant is single-sided deafness, asymmetric hearing loss. Even if you have a hearing loss of just 40 decibels, with a high frequency loss more than 80 decibels, you can still do a cochlear implant. So indications are expanded so much where at some point of time, hearing implants is going to be the permanent solution for a lot of people with their hearing disorders. Now the key question here is, how do we restore hearing in this case? Now before we restore hearing, and we need to make sure the implant that we use to restore hearing should not damage the existing normal hearing. It does not damage the existing hair cells or existing structures. So this is very important. Right. Now how do we do it? Now there are enough publications to prove that the electroacoustic stimulation, that is the hybrid implant or electroacoustic stimulations in patients with ski sloping hearing loss, outcomes are better. So we're not going to get into detail of that, but I would like to focus on one thing. If you look at, this is the latest synchrotron image of the cochlea. The synchrotron imaging, there are only two places in the world where you can do synchrotron imaging. One is in Canada, there's another place is in Seoul. There are two places where you can synchrotron image. If you look at the synchrotron image of the cochlea, now another misconception what we have, to adding on to what Sandeep was telling, till 2012 or 13, we all know that spinal ganglion cells does not survive beyond the second turn of the cochlea. Now if you look at the synchrotron image, the spinal ganglion cells goes up till the apical turn, and you see there is a hook turn of the basilar membrane. Basilar membrane doesn't end here. There is a hook turn of the basilar membrane which is also noticed. Now the point I want to drive here is, the spinal ganglion cells are present up till the apical region from 20 Hz to 15,000 Hz. Now the question here is, when you look at the patient with ski sloping hearing loss, now we know that the patient has lost hearing beyond 2 kHz. But the most important question is, at what point in the length of the basilar membrane, at what point in the cochlea, this 2000 Hz cells are present? Do you understand the question? The question is, if you look at the cochlea, will you be able to tell at what point of the cochlea you have 2000 Hz? It's very difficult, because the cochlea anatomically is variable. The length of the cochlea is not the same. The length of the cochlea in the right ear and the left ear are different. Okay, you can have cochlea, the cochlear length vary from 20 millimeters to 32 millimeters, and can vary of the same person on right and left. So that is why it's more important nowadays when we go for hearing restoration, we measure the length of the cochlea and the cochlear duct. It is possible to measure. So I'm not going to get into detail of that, but keep in mind it's possible to measure the length of the cochlea. Now why do you have to measure the length of the cochlea? When I measure the length of the first information I know, the hair cells are present, the spinal ganglion cells are present up till the apical turn. Then I need to know the length of the cochlea. Why? Because based on the length of the cochlea, I can choose the length of the electrode to insert. You cannot have a standard length of electrode that can fit into all cochleas, right? So your shoe has to be custom made. There is no one size that can fit into all foot. It has to be custom made. You need to measure the length of the cochlea. Now after you measure the length of the cochlea, now the next question is, after you chose the length of the electrode as well, the next question is, how do you preserve it? Now this is where
I got this data, speech disability, and you see there are people with speech disability, and wherever we have people, we have communication, and wherever there is communication, there would be difficulties, and wherever there would be difficulties, we are needed at various setups. So looking at, per se, when you talk about children, those who are going to special schools and also going to regular schools. So this data this is by the UNESCO report, while the other one is by the District Information System for Education, UDISE. And they say that if you look at this, 89% of school-going children with special needs are in elementary school. 89%. So if they are in elementary school, we are needed there. But most of the time in schools and in India, some IB schools, some good schools, public schools, private schools, they have, and believe you me, inclusive setup is a very fancy word they use to promote their schools. We are an inclusive setup. As rightly said by Karat ma'am yesterday, a lot is being documented, a lot is being put on papers, but very less is being done on ground. So yes, so we know that there's a rising need of SLPs, the rising number of children being enrolled. After NEP and RPWD 2016 and Sarva Shiksha Abhiyan, all these things have actually thrusted this thing of admission into schools. Not only children with regular needs, also with special needs. So we have children there, teachers need help, parents need help, but there are lack of professionals working. So, and school-based service has been a part of scope of practice. So this has been taken from the Isha, what Isha recommends. We have to work in school-based setup, but I don't see many professionals working in school-based setup. So when you talk about the school-based services, there are many things one has to do. So if you're working in a clinical setup, we know what all we have to do, right? You're working in a hospital setup, we know what to do because we have been exposed to such services. During our internship time, we were posted at the hospital, in clinic, in multidisciplinary setup. But in school, I didn't have an exposure, and now I'm called by a school. Now what should I do? Because there are like 2,000 children in a school, and I'm the only one probably. So the full range of services, including roles and responsibilities, this has been taken from Asha. They have outlined very clearly roles and responsibilities, and in detail this topic is dealt, in the Western countries. In India, based on what I have experienced, we are involved in assessment. We are also involved in planning the individualized education plan. Intervention, obviously, we are part of it. Collaboration, connecting, the social connect. In-class supports needed. The progress monitoring and reporting, now this is again a part of direct service. We are involved in it even in a clinical setup. And when to think of the dismissal from service. The child doesn't need a service anymore. Now that decision also is our role and responsibility. So I'll just go into various service delivery models. Okay, like in Nepal, if you are interested in starting a career in school-based, what should I do? What kind of service do I provide? Because in theory we have read a lot, something, and there are many things which sounds too ideal to follow. Okay, so we have pull-out service, we have classroom-based services that SLPs can give. We can have self-contained speech-language program, again a direct service, community-based program, wherein schools take responsibility of a particular area, community, and the SLPs working in school, then they have an outreach program, and there are also various indirect services. So what all services I'll be talking about, I'll be kind of connecting with theory and practice. So when you talk about pull-out service, a very common service. So I am a speech language pathologist, I go to a school and I'm employed by a school. For example, I'm lucky enough to be in a city where schools employ. Like, okay, so I'm in Delhi and this particular XYZ International School has a vacancy. I go there and I've been, because they already have a setup. Remember, we are in a stage wherein SLPs will be needed only when there will be a full-fledged system already running. Special ed will be there, counselor will be there, and then only they think, okay, we need a speech language pathologist. So we are not the primary prerequisite part of the team right now in Indian scenario. So we go there and the counselor has already identified, the special ed has already identified, teachers with their knowledge have already earmarked a few children, and they say, okay, ma'am, you please try start giving therapies. Sometimes, to my surprise, when I say I need to assess, a special ed tells me I have already assessed. So that kind of gives me like, okay, you already assessed the communication part, good. But I'm an SLP, I need to do that too. And every minute counts because you're paying for, the parents are paying for it. So, so you do a pull-out wherein you just earmark a child and you have a time that fits into his timetable wherein he's free, and you ask the child to come to your room. You are being given a very fancy room. In very good schools, a big room, and you do a pull-out. It's a very common service that is being given, and you can also have it in a school small group setup. I will admit here that for the last 16 years I have been to school-based program. The group therapy sessions I have been able to take only from last year. Just last year. Earlier it was only individual pull-out sessions. Classroom-based services. Now, classroom-based services is where I, as SLP, go into the classroom with a regular teacher. We have goals, so we either split goals or we work on common goals. We may have corners. All these sound very fancy in the US setup. In India, very difficult. Because if I want to observe a child in a classroom setting, for example, a child's stuttering behavior, fluency behavior, speech behavior in a classroom setting, I want to observe. Sometimes teachers tell me, ma'am, you can't observe in a class. So I have to rely on the CCTV camera when I can't hear anything. So classroom-based services is like far from reality. The teacher is not comfortable in, you sitting in the classroom. The question of both of you working together is far from reality right now. But it does happen. In theory, it is given, classroom-based. Self-contained speech language program, wherein a group of students or children with identified difficulties come to speech and language room, or they have a speech language room mandated. So this, I got the experience of working in such a setup in a very small city, Bikaner, but then we did have this setup. Whatever you take from the Western countries, school-based, one common term will be the common IEP goals. IEP goals. That means you're working very closely. Ultimately, the goal is education. Understand it and render my help to them. So, self-contained classroom is one option. Among indirect service options, we work on the monitoring, the consultation, the curriculum support and the instructional support. So all these 4 services are being given by SLP to children, to teachers, to parents and school setup. Now coming on to the key components of the roadmap. Collaboration with educational authorities. If I give you 2 scenarios, if you're already working in a school setup, in Nepal I don't think, I heard only 1 or 2 schools, the convent schools or the wherein special they have Somebody told me yesterday, because I have been inquiring what's the scenario in Nepal. So in Kathmandu, I learned only one school has a SLP or has a vacancy of an SLP. I don't know if SLP is working there. So you have a scenario like this, and you also have a scenario wherein the schools don't know you exist. They don't feel the need of your service. I have been to such places. So you learn to collaborate. You go there, make them know you exist. If they need service, make them know you can provide them services, and the importance of the services the children need. Principals, when I go and meet principals, the few of them tell me, in our school, every child is normal. No problem only. See, on policy papers we talk about what NEP, the NCF should, how it should be implemented, what principals should know about children with special needs and what should be done in the ground. The principal feels there is no child with problem. So this could be the scenario with you. This has been with me. So when you have this, so it's important that you start to collaborate. So just because you're sitting in your comfort zone and you're like, I will not go to that school because I get a definite no. You will get a definite no. But approach. Out of 5 schools, there will be 1 school. 10 schools, there will be 1 school that will say, yes ma'am, come for session, an orientation session. I'm going to go in detail about what path I took. Tried and tested. Okay? But then start to collaborate with educational authorities.
So this auditory neuropathy was, the term was first introduced by Star et al. In 1996. And there were earlier reports also of children with absent ABRs but responding to sounds. Way back in 1979, Devish and Hurst had reported, and similarly in 80s also many authors reported that. So it's not a new disorder, but it was there, but only thing was that we started giving it a name later on and started identifying it. By definition, yes, auditory neuropathy is a hearing disorder in which sound enters the inner ear normally, but the transmission of signals from the inner ear to the brain is impaired. Okay. So, and the auditory characteristics are consistent with the normal outer ear function and abnormal neural function. Now, this auditory neuropathy, now we also call it as auditory neuropathy or auditory dysynchrony. The term auditory dysynchrony was first given by Berlin et al. And Star et al. In 2004 described it into 2, presynaptic and postsynaptic. Presynaptic was when it is hair cell involvement, and the postsynaptic is when auditory nerve involvement. So the onset could be from birth to 60 years of age, and of course it is most commonly seen before 2 years of age, and the incident rate varies from 0.54 to 11% in different population groups, and with the female to male ratio of 2:1. And the incidence has been reported to be as high as 1 in 185 individuals, and it's not a rare disorder, it's quite a frequent disorder. A major risk factors for ANSD include the neonatal anoxia, the neonatal hyperbilirubinemia, congenital brain abnormalities, low birth weight, extreme prematurity, and ototoxicity. Out of that, the neonatal anoxia and the hyperbilirubinemia are the most common risk factors. Coming to the clinical characteristics, yes, there is inconsistent response to sound, speech understanding is poor than predicted by the audiogram. There is a speech understanding poor in the presence of background noise, and of course difficult to learn spoken language through listening alone. Then the Pioton or behavioral thresholds can range from normal to profound. Yes, there is an impaired temporal processing, that is a hallmark of this disorder, and then poor thresholds in the low frequency also have been seen, and hearing aids may be of less benefit than expected. And in addition to that, yes, there is acoustic flexes would be absent, no ABR as we discussed earlier, large cochlear microphonics, present OE that do not suppress with the contralateral noise. That again is one of the characteristics. There are absent MLDs, especially when we do in adults, and of course the auditory processing is affected in noisy environment. Coming to the pathophysiology, though it is not very clear how it happens, but yes, some people have tried to explain it. There is a abnormality in the synapse between the primary neurons and the inner hair cells, which leads to a kind of a temporal jitter, and then the nerves are no longer in phase lock. Okay, that's why the AVI is absent. So, or there could be a loss of inner hair cells or auditory neurons, so that fewer or no spikes are evoked in the auditory nerve. And it's of course, these selective junctions could be poorly developed. There could be injury or degeneration to the selective junctions between the inner hair cells and the dendrites of the spiral ganglion neurons. There could be direct injury to the spiral ganglion neurons. Okay, or there could be, there could be injury, there could be missing hair, or there could be damaged myelin sheath also could be there. Because of that, the conduction does not take place. It could be presynaptic or postsynaptic. Presynaptic is when it is affecting the inner hair cells and the ribbon synapses. Then it could be postsynaptic. It could be unmyelinated auditory nerve dendrites, or it could be central auditory. So the lesion could be anywhere along. Okay. So it could be presynaptic or it could be postsynaptic. And it involves, once we have some suspicion of ANSD, so a comprehensive evaluation requiring an interdisciplinary approach should be used, which would include the otological examination, the radiological imaging, CT, MRI, neurological examination, then even the medical genetics to find out whether there could be syndromic or it could be non-syndromic disorder also. And then of course the detailed audiological examination, I'll come to that, and of course the pediatric and developmental evaluation should be done. So it has to be a comprehensive interdisciplinary approach to identify as well as manage patients with ANSD. So the audiological investigation would involve behavioral audiometry, VRA, BOA, play audiometry, depending upon the age of the child, total audiometry for older children and adults, speech recognition testing, then immediate measures including the tympanometry and the acoustic reflex testing, and ABR, and then orthoacoustic emissions. It has been seen that large percentage of these cases usually have symmetric hearing loss, around 80 to 85%. And different types of hearing loss configuration or audiograms have been found, and these individuals, majority of them would have flat audiogram, but one-fourth of them could have a reverse. It means the sensitivity is poor in the low frequency as compared to the high frequencies. Point needs to be keep in mind, when we are assessing these children, that yes, there could be fluctuation in hearing loss. Okay, so when we measure it over a period of time, one time you might find that there is a hearing loss, another time you might see that hearing might appear to be normal. Or even sometimes, within same session you see there are momentary changes, and many times these, especially adults, they have been found to be perceived as having malingering also, because sometimes they respond, sometimes they do not respond. And of course the speech perception is out of the proportion with the total audiogram. So, and there is perception of stop, nasal, semi-vols and diphthong, they are very poor, and there is a discrimination in the lower spectral range also severely disordered. Then the different expression of OEs that normally happens in normal individuals, that could be absent, or there could be minimal suppression, okay, and it could be due to the efferent deficit rather than the efferent deficit. ABR protocols, it would be more or less same, but yes, two important aspects which need to be emphasized here is that you need to have separate runs of rarefaction and condensation, because when we do, then we get cochlear microphonics. If we are using alternate polarity, cochlear microphonics get cancelled out. Okay. So the other thing is, when we are measuring these cochlear microphonics, we have to have, preferably should be using the insert earphones, and to verify whether it's really cochlear microphonics or some other artifact, you can do a what is called as clipping of the tubing. Okay, if the cochlear microphonics are if some activity is still present, okay, I'll show you with the next diagram. So here you can see, so this is with alternate polarity where could not see any response, but yes, this is with the rarefaction and condensation. You can see they are the mirror images of each other, and this is with the clipping.
Dr. Rufali Masur, she has more than 12 years of experience in her field, and she is a consultant speech language pathologist and audiologist, and at Sabda Brahma Speech and Hearing Center and Cochlear Implant Center in Ahmedabad. And she completed her master's degree in speech language pathology from All India Institute of Speech and Hearing, Mysore, in 2010, and she completed her PhD in efficacy of voice therapy in dysphonia using multidimensional assessment protocol in 2017. I would like to call upon her to present her multilingualism and cochlear implant in multilingual environment.
So my topic is multilingualism and cochlear implant. So we are a SLP, so we study a lot about many languages, bilingualism and multilingualism. But we have to see how the children with hearing loss who are using cochlear implant, whether we can teach them the language, one language, two language, or other language also they can learn. Is it possible? So we will see, because as we know, India is a multilingual country, and I think Nepal is also a multilingual country. So first I would like to start with the quote. So one language sets you in a corridor for life. So you can go in the life, but if you know more than one language, it opens every door along the way. And multilingualism promotes culture. So when yesterday there was a function, so we had many performance in Hindi, Nepali also, and in Bihari also. So there were some songs. So the language promotes culture, and culturally diverse children is better to prepare to participate and compete in global society, because we are not going to stay at one place. We want to go other places to exchange our ideas, and we want to learn more and more. So this was just, when I came to Nepal, I was trying to learn how many languages are there. So there are many languages, mostly it is Nepali, so 40% Nepali. So what I understood is most of the people, they know Nepali, some know English, and many of them know Hindi also. So they are multilingual. So it is very important. So when you are dealing with the children with hearing loss who are implanted, so how you can start teaching them different languages? What is the process? So initially, this was the initial time, people thought second language would interrupt learning of the primary language, and it can cause delay also. But however, research has been done on bilingual children and theory has disproven. Okay, so sometimes there will be a lag in one language. It is not necessary their proficiency will be same in both language or in three languages they are speaking. So there will be a difference, discrepancy will be there. But however, the lag can be temporary, and they eventually catch up with the peers. So for multilingualism, many things are needed. So if they have a good spontaneous language models at home or at the school or society, so they will learn many languages easily. They learn many times incidental language learning is seen. So through that they learn many languages. And so in early childhood, that is very important. When child is early, like his young age, the mind is developing and he can learn many languages easily. So what we see in children with profound hearing loss, first is important, like task is there to oral language competence. They will learn the language. That is also a big task. So they will have inadequate exposure to complex phonetic and suprasegmental patterns of the spoken language. There will be difficulty in incidental learning. So, but what happens in nowadays? Children are getting implanted at very early age, and the implant gives the broader access to the hearing aids compared to the hearing aids. There is high degree of resolution, so they learn more of incidental and natural language. And nowadays, so children are getting implanted 1 year of age, or some are very early also. So recently I attended one workshop there is one center there in India also, 7 months of age also child got implanted. So they are getting implanted very early. So that is very important, and then the child can learn easily language, first language and second language also. Call 2066 also represented a 3 language will not confuse a deaf or hard of hearing child. So I went through one critical review. So they studied many language retrospective, what they said. most of the studies say they can do, but however, retrospective study found that bilingual children with hearing loss did not perform as well as the monolingual peers. But however, there was some lack in the methodological discrepancy with lack of background variables, family background, degree of second language exposure, living environment. So I will be talking about these points which they did not discuss. So those are very important when you are deciding for the language, which language to use, how you can support them.
Take care of one sense, that is hearing. We would definitely give that child with improved quality of life, of course, and communication skills will become better because the child is now getting awareness towards sounds. And we all know that once they start hearing, they become more attentive. The hyperactivity, the attention deficit also starts coming down. The most important thing that is being here is social interaction and connectiveness. So the children, when they have additional needs, and if the hearing sense is retained back, they start getting connected to the society. We only focus on the oral or speech and language therapy, but here we also have to focus on the social connectedness. So what factors will lead to a better prognosis? Of course, like with hearing impaired, only hearing impaired, the earlier the better we say. The age of implantation is very important. Then the frequency and the amount of therapy. Yes, frequent sessions, multiple sessions throughout the week. The listening environment. Yes, the quiet and listening environment. And of course, like we say, the parents are the key home takers. They are the ones who are going to have the naturalistic settings, continue the same therapy modalities at home. So naturalistic settings and carryover is very important. In addition to the carryover, the support for the other disability also is very important. So they should have support for the other needs that they have. Then moving on to my second question that had come to my mind was, do all children with additional difficulties receive cochlear implantation? Are there any expectations? So when I went around and asked different clinics, what I found was there was no consensus. Even in India, some people were saying that no, there is no point. Some people were saying no, at least we take care of one disability. So what I'm going to show are the factors which we gathered across when we were interviewing different clinics. So first, there was lack of consensus in literature, and regarding benefits, they say कि even literature में भी तो बोलते हैं कि शायद multiple needs वाले बहुत कम progress करते हैं, that much progress नहीं. So based on that, a lot of clinics had different viewpoints. Then possible outcomes जो है कई बार they are disappointing for the families. So families might be disappointed कि उतना नहीं बोला जितना उसका बच्चा बोल रहा है या हमारा बच्चा उतना नहीं बोल रहा. So disappointing for families. Challenging programming the device because they have additional needs. Even as clinicians, we face a lot of challenges while programming. Mapping, they have to come for multiple sessions for mapping. Frequent programming is needed because we will not see clear-cut responses. Autism spectrum symptoms will not lead or will lead to the shadowing of the hearing disability that is occurring. So both of these lead to severity increase in these patients. Still, what it is being said is now in PGI we have almost more than 500 cochlear implantees done by now. Different companies, different age groups from adults and children. What we are also seeing is more and more children with additional needs are coming under this program. So almost 25 to 50% children are getting cochlear implants. And why is that happening? Because we have become more confident. We have become more confident in programming. We have become more confident in handling pediatric population. And that has also happened because of the company's technology becoming more and more advanced. Less participation is needed from the child. We can give a lot of NFS-based map, a lot of, I'm sorry, I'm referring to one company, but yes. Now, what were the challenges in intervention we faced? Any special considerations with the CI team? Yes, the number one thing that we used to face is that expected behavior. The children with severe sensory issues, they will not even place the implant. They will just throw away the implant, or they just shake their head and remove the implant. So we have tried multiple things. So we used to have children put implant on their caps, in the bands, on the headbands. We sometimes even used micropore to temporarily hold and let them get used to that the device is on. So these techniques worked very well with a lot of patients. I'll show you a video in the near future, but before that, a few more issues that we faced. One was retention because of anatomical issues. So we use double-sided tapes, but we have to look for redness and irritation on skin sometimes. So it can cause, so we'll have to be cautious about that. with children having wheelchairs and metal backings, so the coil would come off. So their placement of the headset pads, all these adjustments can be made so that it is at the level of neck and not at the head level. Wheelchairs used to make the coil on very difficult. So in those cases, we had indicator lights on, or the child, if they was old enough, they would tell after a few months of training, they would tell that the head coil has come off or I'm not listening. We have to be cautious about increasing the magnetic strength to the brain because it can be a little dangerous for the skin flap. Also, sometimes we use this off-the-ear processor at the level of shoulder. That has also been very useful because the longer coil and all these things can help in better retention. Any additional considerations that need to be discussed with patient's family? Yes, preparing the family is very important. Now what happens is family comes with a high expectations. उन्होंने 5.5-6 लाख रुपया लगाया है. They come कि पहली बार में when they switch on, the child is going to respond and they're going to listen. But with multiple needs children, the responses may not be जो हम दूसरे बच्चों में भी देख रहे हैं. So what happens is we cannot predict an accurate response sometimes. Sometimes there is no response at all in these patients. And sometimes more time is needed. Frequent mapping, slowly, every week calling or twice a week calling, this helps. And we have to tell them that programming is a journey. It will not be done in one sitting, it will be a journey and many more sittings will be required despite they have to come from long distance. I'll show you a video of a child. So this child has severe sensory issues and this is the day of initiation when the processor was switched on. You can see that he was only shaking his head, making some noises. The mother could guess that this was a happy response for the child. The child felt very happy that now he is listening. So the typical response that you get in other children, you might not get in these children when you switch on them. Any special considerations during mapping? Like we have been saying again and again, behavioral maps will be difficult. So you have to concentrate on NRT based maps first. Condition maps should be done, but you have to be patient with the parents, training that it will take a long time and multiple sessions. The dynamic range has to be narrow in the beginning. And you can give progressive maps. When the child gets comfortable, they can switch on to the next map. And desensitization, like that child where I just showed you the video, they are very sensitive towards the loud sound. So you have to desensitize them gradually and very slowly towards the loud sound exposure. Develop a conditioned link sound response first. That's our first goal. Then we move on. If the child is not giving a conditioned response, at least pointing, eye gaze, any kind of response towards the link sound. Then from there we move on to vowels, other vowels, consonants, diphthongs and other, so on and so forth. If you record, you will be able to correlate it what parents are saying and what the teachers are saying. You have to collaborate with all of the team members of the family of the child and the teacher to see that the responses are accurate. And if there is facial twitching, we have to be very careful, manipulate the pulse rate and the pulse rate. Now the red alerts, the last slide for mapping. At least for mapping, we have to be very careful that if there is a decreased speech perception or production abilities are reduced, we have to be careful that probably the child is not listening. We have to go back and recheck our maps. Unusual stimulation, the child is feeling some pain or buzzing, again we have a red alert for redo the mapping. Parents or therapists are saying कि अब आजकल ये आवाज़ पर ध्यान नहीं दे रहा है या सुन नहीं रहा है. These kind of things make you red alert that probably there is some problem with the map. Then behavioral changes. Sometimes we see that because they have additional needs, they'll suddenly show behavioral changes. बहुत irritable हो जाएगा, बहुत temper tantrums throw करेगा. These responses also may be indicating to us that child may not be able to express that audition is not there or there is an issue with them. Minimal progress over a period of time. I think everybody knows that progress नहीं है हो रहा है, तो we have to go back to that. I'm seeing a smile on the therapist's faces that yes, this is very important to go through. Then there can be retention issues. बहुत सारे our interns and students will come back. मैम सिखाया था हर हफ्ते भूल जाता है, फिर आता है अगले हफ्ते फिर वही करा, फिर भूल जाता है. So there are probably retention issues which you are not assessing and which you are not looking at. So there can be learning disability, PDD, MR, they will not be able to retain the syntactical and morphological markers. So what is the syntactical and morphological markers? Vakya, I don't know Nepali, but Hindi I can tell you. The grammatical markers जो आपके हैं, रहे हैं, all these verbal and grammatical markers जो हम sentence में use करते हैं, all these will be there. So what do you do in such cases? You have to make very small incremental steps. जब आप अपनी short term goals when you are making, they have to be very minute and not एक से दूसरे पे longer पे jump नहीं करना. The smaller the goals will be, the easier will be to achieve them and show the progress to it. Please tell me when I'm on time. I'm sorry, we as teachers, we go overboard talking. So pragmatics, social communication disorders, and semantic, and these issues can be there. So 2 new techniques which we have come across is association method. This is a very good technique where they are incorporating oral, language and literacy into one. So they are using phonic skills where the written, you'll see online a lot of videos, वो बच्चे को ऐसा पढ़ा रहे हैं, written alphabets are there and they are joining it with the oral or the language that he has already learned. So they start from oral language building, then sentence structure, then bringing it to the textbook level. So they are associating and it helps in a lot of literacy development in these patients. Next is your ABA, very frequently used. It is based on reinforcements, contingent behavior. So negative reinforcements are used to decrease any undesirable behavior. Positive reinforcements to increase the desirable behaviors. Like social communication में वो turn taking नहीं कर रहा है, रुक नहीं रहा है अपनी turn के लिए. You know that he's not waiting for other person to let the other person speak. So ABA works well in such programs. And then home programs can be given for the parents. Then the other challenge can be learning new content, making connections, vocabulary. Here a multimodality approach is being used recently. The acronym that they use is BASIC ID. So BASIC ID mein there are 7 things: behavior, affect, sensation, imagery, cognition, interpersonal and drugs and biology. They say all these 7 work together and somewhere or the other one of these personality traits of the person is what is hampering the progress. वो बोलते हैं कि genetic और environmental दोनों का इन सब का there is a merger, and as a therapist we have to work on one of these traits to improve the further in child, to make the content and learning better. Next is the cognition and memory. We all use this in aphasia patients, stroke patients में आप जो cognitive rehabilitation करते हैं that. This works well when you have attention, memory or any one aspect, you know, very severely deteriorated. So you work with cognitive rehabilitation on those. So restoration and the regaining of those tasks. Lastly is literacy and phonological awareness and phonic skills. Here there is this Gardner's multiple intelligence framework that has come. This has another 7 levels of intelligence: linguistic, spatial, interpersonal, intrapersonal, naturalistic intelligence. And he says you know that you have to work on all these 7 domains. A teacher should work these 7 domains to go through and get through your students. So there is a long network and guidelines that has been given under this. These are some of the activities that we use in our clinic to build attention and concentration skills. So I thought it will be helpful to just quote it. This was some steps that we built for attention, like the parent is outside, they're knocking at the door and then they are attending. The second one, there is a radio, you can see that the radio is making noise and then the mother says, listen to the sound. The child is listening and gradually the sound which they are supposed to listen to, वो कम कर देते हैं and radio का आवाज़ बढ़ा देते हैं. I think all of you must be doing this. Third one, we use the Simon Says games. Simon Says, everybody knows? Simon Says, raise your hands. Nobody is listening. Only of you. Touch your teeth. Alert. Simon Says, touch your head. Only 5 or 6. So what you have to do is, you have to listen whenever there is a Simon Says, only then. So the sustained attention is that the child has to listen to the command, then do the action next. So children, what they do is, they keep listening to when the Simon Says come and then they have sustained attention with that. Then there is another thing that we play with children who have like Kannan sir is saying some story, he ends with the Kala Pani and then Na comes and then I have to start building a story on Na and then I finish something and Shefali goes on. So last word जो Kannan sir का होगा वो मुझे ध्यान देना होगा, मेरा जो last word होगा वो Shefali को ध्यान देना होगा. So there is a sustained attention and language development, both occurring on the same go. The last one is sustained attention for sound stimuli. Here we use longer sentences. Together, 4 or 5 commands and children have to keep doing and in that order. So that builds more sustained attention for sound stimuli. Again, a few techniques, I've just listed them. I think all of you know because you all are doing AVT here. Listening environment, a quiet environment, a very auditorily enriched environment for them. Hand cue technique, जहाँ पे हम उन्हें बोलते हैं, listen now, something important is coming, so you have to listen. Highlight, where you have to highlight certain words through pitch and intonation inflections. Auditory sandwiches, you all know AVA, auditory, visual, auditory. So what you have to do is, no, somebody nodded no. So I'll just highlight a little. AVA is, you go auditory, you make the child listen, then show him, then again listening. So it is very important, the last A, because if you have just shown him, he might start lip reading. So last auditory is the most important, so auditory sandwiches, that's why it's called sandwich. Okay. Then parent participation, turn taking, moving along a continuum of cueing means gradually you reduce the cues. And child's communication mode also, you have to pay the most attention towards. Some apps that we use, apps have become very prevalent. So some apps that we use, Get Talking app, this one was specially for CNCI. Avaz, that is for autistic children, Look at Me, Hear You Now, Stepping Stones, Talk It gives voice to people with speech disorders, and Be My Eyes. I don't know how prevalent they are here, but here in India, in a lot of private clinics we are doing it. Okay, quick. Okay, the crux of this slide is that we have to be goal driven. एक बच्चे के goals दूसरे के लिए नहीं use किए जा सकते. Every child has individual goals and every child has to have small incremental goals. Multi-sensory approach, audition may be best modality. You will see slow and gradual progress. This whole slide says it may take months. It needs the whole participation of the family. Then alternative modes of communication. I think you all must be knowing this. Simultaneous, American Sign Language, contact signing. We also use Makaton there. Like we have now Indian Sign Language. I'm 7th level A graduate of Sign Language. I don't know about here, if you have another sign language developed, no? Team members, I'm going to skip these slides, you all know additional team members. The only new few, the teacher of the deaf, the physical therapist, behavior therapist, vision, they all new team members come in picture. So working together is important because we transfer the ideas to each other. किसी एक clinician के साथ कोई चीज़ work की, it can be passed on to the other. So it is very important to work as a team. And this is the most important, I feel. I would not want to skip this slide because parents have a lot of emotional issues. They are in denial. Already they are feeling कि why we? हमारे साथ क्यों ऐसा हुआ? They are in grief. और ऊपर से they have to deal with so many clinicians. एक AVT therapist है, doctor है, ENT doctor है, occupational therapist है. So please be very, very patient with them. So that's the most important thing. I'm going to skip this. Last two slides, bilateral cochlear implantation करना चाहिए कि नहीं? Yes, the two important slides here are bilateral CI is needed, 2 slides, that's it. Oral language development is faster if you use bilateral CI, and independent, the child becomes independent, and this is the most important. The parent told me, ma'am, मेरे लिए oral language development इतना important नहीं है, उसका social connectedness और आवाज़ को सुनना is most important. वो आकर बैठ रहा है, he feels connected with his peers is very important for me, which they saw with bilateral CI. So we have to make sure कि हम उनको oral speech and language के जो उनके scales हैं उस पर judge नहीं करें. Outcome scales भी important है जो आप choose करते हैं उनकी habilitation में, management में और उनकी rehabilitation में. Thank you. So,
let me introduce Professor Wasim Ahmad. He is expert in audiology and speech language pathology. And he is professor and head of Department of Speech and Hearing, SDM College of Medical Science and Hospital, SDM University. And former founder principal, JSS Institute of Speech and Hearing, Dharwad.
So coming to my topic, aphasia is something which I love to work with. Aphasia is an acquired communication disorder because of brain damage. And we often see 4 important symptoms here, that is difficulty in speaking, listening, and most importantly reading and writing as well. And it is not because of any sensory or motor deficit, confusion or any psychiatric disorder. So in this disorder we can classify it in many ways. The most common way of doing it is fluent and non-fluent type. I'll be trying to focus on the non-fluent type of aphasia where the comprehension is much better compared to that of fluent aphasia. Before we begin, we need to understand three things here. The stages, the acute, subacute and the chronic stage. Most of the time we see in hospital setup the acute and subacute conditions, but chronic is something which we don't usually meet very often because they do not come back to the hospital. Getting them to the hospital itself, the logistics is a big problem for the family. So this is where I enter and try to modify it, where I go to their house and start doing my work. So whatever the work that you see here is in home visit. Acute and subacute conditions, we are not going to do much about agrammatism until and unless it is really spared that the person is able to have one word level utterance. Then comes the naming recovery. Most of the aphasiologists these days are worried about the naming. And most of the techniques that you see are dependent for the anomia. So you are worried about how many words this person can say, but how do you join the words together? Not many people are really working upon it. So having 200 words, 300 words, is that enough? Is that how we speak? No, I am speaking to you in sentences. We all speak in sentences. One thing that we forget is this is a normal person just before the stroke. He was speaking like all of us. He was speaking in sentences no matter what language he was speaking. So there was grammatical units, there were different kinds of sentences. It was not just a direct sentence. It was a combination of many things that came from his thought, his heart. So we should try to get back to that. So natural language processing is something that we should be focused upon. So putting agrammatism into a nutshell, it is a symptom complex that we often see in non-fluent type of aphasia. Paragrammatism is that we see in fluent type of aphasia. I'm not going into that domain as of now. So in agrammatism, we see they have erroneous sentence production, which are smaller and very simple, and they have only strings of content words without any grammatical units being properly put there. And they have more difficulty producing verbs compared to nouns. The literature has it very clearly. And we do see this. You ask them to name nouns after, while they will be able to. If you ask them to name an action, they will not be able to do it. And once, if they are able to even put the action together, the thematic roles that come into that sentence, who is doing it, why are they doing it, when they are doing it, they will not be able to put it together at all. A person who was able to do this right before the stroke is not able to do it. We should not forget this again. The beauty of verbs, it defines action or event, but they are the fulcrum of a sentence. They are the main core of a sentence. And they cannot exist on their own in a sentence. If I say, Dod raha hai, kaun dod raha hai? The immediate question that comes is, somebody has to run. So similarly, they need to get associated with different arguments. Arguments are the ones that are the different roles that are put together across the verb. So the association or the romance between the verbs and the argument structure, the interplay, is called as argument structure. Okay. So there are different types of arguments. I'm not putting a exhaustive list here, but the most commonly used ones is the agent, patient, theme, instrument, location, source. That means who is doing it, where are they doing it, when are they doing it, why. These are the aspects that we call as arguments. Based on the number of arguments required by a verb, the classification comes. One argument, two argument, and a three argument verb. As I said, running. Who is running? That completes the sentence. Girl is running. If I say admiring, somebody has to admire somebody. So there has to be an agent and there has to be a patient. So father is admiring. Okay, who? So you can't complete the sentence without putting both of them together. Three, shoving. Okay. He is shoving the clothes into the cabinet. So there has to be a place where the clothes have to be shoved. So there are three arguments. So verbs require these obligatory nouns. Anything apart from this obligatory becomes optional argument. So the most common features taken from the entire literature, I can put it into this one slide, is morphological deficits, word processing deficits, syntax comprehension deficits, and sentence structure deficits are the most common aspects in agrammatism, whether it is the Western literature or the Indian literature. So if I just highlight a few things, simple SOV sentences, this is for sentences that we see, or SVO sentences based on the language that you're seeing. That means the maximum that they can do without any intervention could be the natural recovery, somebody doing something. That's all. And the greater the argument level for each verb, the more difficult it becomes for them to produce. So they get these verbs which are easily put together, that is single argument or maximum 2 argument verbs. Even we have a misconception that there is no comprehension deficit at all in non-fluent aphasia, but there is comprehension deficits as well, and especially in sentence processing. So the Western literature also has been reflected here in the Indian literature, as I told you. The very early work from Madam Karanth in the 1990s, where she elaborately mentioned what are the different agrammatic features that we see in Tamil, and other studies also that includes Dr. Rajshekhar sir and Dr. Chengappa, where they spoke about the agrammatic features in different languages. But we were more focused on exploring the features and the the symptoms or symptomatology of agrammatism, rather than looking at how to solve this issue in the earlier era. So when I looked into the literature and I found it, what I found was that the Western clinicians have standardized tools both for assessment and for treatment. Now, if you have such standardized and validated tools, it becomes easier for cross-central and cross-cultural comparisons. Next, if we have these standardized tools, we are able to identify the actual disturbances in the client's language, and we'll be able to help them effectively even before and manage after the therapy as well. A person should be able to comprehend and express verbs. He should be able to label the arguments along with the verb, and then put the case markers and the inflectional markers to make it more meaningful. So this is what a test or an ideal test should be able to do. Unfortunately, none of the tests developed in the Western region have the ability to do all of this except one, that is the NAVS, or the Northwestern Assessment of Verb and Sentences from Thompson. It was recently developed in 2012, where it can do most of these things, including the noun phrase and the WH movement that we see in English word order language. So there are a few techniques that I would like to highlight from the Western region, that is the VNest. This promotes not only verb and word retrieval better, but also to join it together in order to form basic sentences. Then going further to TUF. TUF is the treatment of underlying forms, which comes as a combination of the previous test that I was mentioning, NAVS. So NAVS and TUF come as a package. So you assess, you treat, and you reassess.
So that is the approach what most of the surgeon follows if they suspect any growth in that ear. The Indian experience, if I talk about BAHA and BCI, so from 2000 onwards, I could get the data. So with respect to BAHA, 350 patients, some with processor, soft bands and sound arc, and in terms of like medal, 126 BCI. This is the data from till September. I'm sure that a few more have been added in that. So it would be around 134 or 135, almost 10 you would have done, because one we did. So poor awareness about the bone conduction solution, that is the major thing why people are not coming up, and we don't have any schemes which support this. So people say that it's not that much of impactful. Anyway, I'm hearing people they have to speak a little louder, or the other ear is working, single-sided deafness, so they don't want to go for that. Service-related issues, of course, these devices are costly and the services are also costly. Okay, so it is considered in the physical damage kind of thing. So such things like cost a lot. It is almost coming to 45,000 Indian rupees. So patient, they fight with us, they don't fight with company. So what I do, I give the number of company representative, fight with them. So difference between bone bridge and BAHA attract, if I have to talk, in terms of stimulation, active and passive. When I say bone bridge is active and BAHA is passive, directly applied to the bone, it goes via skin, so there is a dampening. Audio processor picks up sound and transmits, picks sound, turn in vibration and then transmit. The implant is BCFMT, and implant mainly has a magnet over there. Transducer is BCFMT, transducer is a plate. Skin consideration, bone bridge is low pressure device, whereas in BAHA BAHA tract is 4 times higher than bone bridge, what I have noticed. So wearing comfort, it is lightweight, 8 grams, that's approximate 15 to 21 gram, including plate and battery. If I have to talk about 602 versus OCA2, the latest processors what they have, latest system. Surgical comfort, flexible transition is there. There is less flexibility. Audio processor battery, that is 7 to 10 days, and rechargeability is there, where it is 1 to 10 days and no rechargeability option. Implant fixation, in bone bridge you saw that the two flanges are there, so you fix the bone bridge at two sides, whereas in OCI it is single point. So there is a fear at times that it might get dislodged. So that's the what I feel personally. Transducer, this is BCFMT, and there is piezoelectric substance. For India, the color option is 1. They say they have 23, but they provide 1 in India. Sorry, Sefali. And the OSIA, there are 4 different options. Hands-free calling, yes, with Samba 2 Go and Minitech, and it's not there in OSIA. There are some studies done on the adhere, and they have found that there is improved in word recognition score when the adhere is used. Sound localization improves, and speech understanding in noise is improved if the signal is from deaf side. No adverse skin reaction. This is more important for kids, younger babies. I am proudly saying this, first for India, we did BCI 602 in Ahmedabad this year. And he was earlier using a different company device, but he wanted to go for an implant, and we said like you go with BCI 602. So few of our clients, you can see the left side, this guy has been operated several times by plastic surgeons, general surgeon, for the pinna reconstruction, and it failed. And later on he got the bone conduction done, and he's happy. He's working in Bangalore, he's an engineer. And that girl, she's like adhere user. She doesn't want to go for any surgery. She's scared of that. So we did the first in Gujarat for adhere. The guy in the newspaper cut was a poster boy for Cochlear, the Baha system. And in 2005-06 he got the Baha on band, and later on he was implanted. And the caption says, "Kanma kanu na hoy to pan sambli sake." So if there is no ear canal, then also you can hear. That's the caption. And he got the Baha that time, Baha with the abutment. And now he's a grown-up individual person. And proudly again, the caption from my Facebook post: "Moon mission, hearing mission." The day Chandrayaan 3 did landing on moon, just 2 hours before I did Baha 6 landing on his head. So this is another adult Baha BP 100 user. She is also having like rudimentary ear pinna, and she has been using this device over 10 years, and I am very happy the care what she takes off. She has not come for any repair. I am thankful for that. Bilateral bone bridge. So how many of you would suggest bilateral bone bridge or bone Baha? So even I was like, why you need? There is hardly any attenuation of bone conduction sound. So this gentleman Neeraj, sorry I said his name. Okay, so this boy came to me and he said like, I want to have some solution. So we suggested him bone conduction option, and he went with one side bone bridge. And down the line he went for some studies, higher studies abroad, and there he took a trial on the other side. So he liked it. He said like there is a wow factor. I could feel the sound is more rich in noisy conditions and all those things. And he came to us and he said, why didn't you operate on the other side? I said, we didn't feel like, and why you would spend that much amount of money. But he said, no, I like it. You give me trial again. And we gave it, and he was like, I want to go for it. So we did first bilateral bone bridge. He's cricketer, guitarist, student. He was now entrepreneur, dancer, and he feels it's more clear and comfortable. There is a wow factor. These are his words. There is a testimonial. I'll play if the time permits. So again, yes, bilateral bone bridge, Asia's first. So the type of devices which can be used in such situation, you can have sound arc or the bone conduction arc, the spectacle hearing aids. This on the right side, this is the indigenously developed device from a company V here, but the site of placement and all that is weird. I didn't like it. Baha on band,
and you have already seen adhere. So the contraindications, retrocochlear pathology component is there, you should not go for it. There is problem with the bone, infection is there, osteitis, then you should not go. When you need high resolution CT scan, then this can be a problem because the area would be masked. Skin, scalp conditions, then that you have to check. Intolerance to the material used, then that can be a contraindication. There have been studies like they have recorded ABR and cortical potential following bone anchored hearing aid stimulation. So take home message for SSD, it's like candidate selection should be proper. It improves listening in noisy condition. Good counseling is needed to explain the benefit and limitation, and you must say that it doesn't improve directional hearing in all planes. So it's not for the directional hearing. This is a paper for the unified testing framework developed for single-sided deafness, a consensus paper, and I'm happy to say that Professor Ranjit and Professor Mohan were part of it. And this is what the framework they gave, like screening should be done and then should be randomized trial for different devices for a few weeks, and the choices then could be given to patient whether you want to go for a cross, bone conduction device, cochlear implant or no treatment. So the take home message, there is very poor awareness, so we have to improve at the level of patients, surgeons and audiologists. We have to think of some indigenous device if it can happen. Shefali is staring at me, what about metal then? Okay, so we have to bring the cost down. There should be more government program which supports these kind of implants as well, state government program or the government and the central government ADIP scheme. I could get some time to move around in Nepal, and it is very great country, very beautiful sights. So I would say it's never ending peace and love, that's what Nepal stands for. We went to our doctor, Dr. Rajesh Vishwakarma. He doesn't want to pay for my consultation. He paid for device. A lot of things he could not do first bench. Just to add on, he got married 2 years ago and his wife is speech pathologist. You see his hairstyle? So it's all covering his pinna region. On lighter note, you should have hair to have that style, right? So jealous of him. I'm also young, sir. Thank you. My sincere gratitude and thanks again to Shan organizing committee. Special thanks to Karna sir and my dear friend Anup, who has managed all my itinerary, and I have called several times to Anup and disturbed him day and night. Thank you very much.
Thank you, our respected chairpersons, for chairing this session. Thank you, Dr. Wasim, for this enlightening speech. So we'd like to move towards the next scientific session. So for that purpose, I would like to welcome Dr. Beena Prajapati to chair the session, who is a Chief Consultant Pediatrician and Associate Professor in Kanthi Children's Hospital. Similarly, I would like to welcome Dr. Intl, who is Associate Professor in Maharajganj Medical Campus TU. Thanks, Rod. I would request the chairpersons to introduce our next speaker.
In the Department of Psychiatry and Mental Health, TUTH, Maharashtra, and he has done PhD in psychology as MPhil in clinical psychology. So his area of his interest is cognitive behavior therapy and application of mindfulness practice.
It's like a nice journey. Actually, it's this type of intensive interaction with SLP fraternity, I think it's first time for me. So, I teach BSLP student in the first year, but in the first year, they are still exploring the field. I always ask them, why are you in this field? Have you really started thinking, okay, I'm into this field? I think they're standing behind. But I've never been into interaction like this, and I think it's necessary. I sometimes fear that we professionals are creating cultures which will become like race thing in 20 or 30 years, that we will be creating this professional culture and we'll start fighting with each other. To prevent that, I think we need to really be humble and work in this multidisciplinary conferences. And thank you, Susmita ji, for calling me, and even where is our MC? So they just called me, I think 2 weeks back, and I asked, what shall I talk? Because I don't know, how can I contribute? And then she said, okay, mindfulness can be a way, but the problem is I'm not expert in mindfulness. Though being a clinical psychologist, just to explore my research interest, I had my master's in Theravada Buddhism, and I'm also trying to do my PG in yogic science, but just as a psychologist, so I don't dare to touch this topic. But she said, okay, that might be a good one. So today's topic will be just an exploration, okay? So I'm not expert in this field. My field of work is psychometrics as a researcher, and as a psychotherapist, I'm a cognitive behavior therapist, okay? So with this disclaimer, I invite you, okay? So at your, so please stop whenever I run out of time, because I'm also not prepared like previous speakers. So I just prepared my slide 4 a.m. this morning after seeing yesterday's presentation, because I've been reading through these things, I know, but the presentation this morning, so might be a bit clumsy. Thanks to AI generated some slide softwares which I had access. So we'll be talking about what's mindfulness, okay? So I'll talk from a psychologist's perspective, okay? Modern psychology, not the Eastern psychologist or so on and so. And then after, we'll try to touch the origin in last 50 years, where these researchers and experts got their idea about mindfulness into this area. And then after, maybe we might go for a small formal mindfulness practice, if you're okay with that. We might go through 6 minutes meditation practice. You can run away, okay? If you just fear about that. And then we might go through some scientific evidence, but I will share you the raw work, okay? Not nice slides as early presenters. So mindfulness, sati, smriti, these are the words used in this part of the world for mindfulness. If you go to the traditional text. So what comes to your mind? In Nepali, hos, okay, hos. So what comes to your mind when someone says mindfulness? Because these days, people are using this term everywhere, okay? So what comes to your mind? Anything? Peace, okay, peace, being aware, okay, I think. Thoughts, yeah. Okay. So generally, This is a person, John Kabat-Zinn. So he was a molecular biologist. 1970, early 70s. He was working with patients in a hospital, and he was also a practitioner of Vipassana meditation. And later, what he did was he tried to combine the knowledge and practice, experiential experiences he gained from that meditation with some yogic postures and awareness exercises, and then he developed one program called mindfulness-based stress reduction. That was in 1979. Even prior to that, people were doing some research on that, but he was the one who really brought this topic in the academia, actually. And so he defines mindfulness as an awareness. For example, we are sitting over here. We are aware that we're sitting over here. I'm aware that I'm in front of the mic, and I'm also aware that I have stopwatch, which I have to go through, but I might forget while I'm talking. This awareness that comes from paying attention to any events. Event can be what goes inside your head, just like ma'am said earlier. Awareness about the emotion, what I'm feeling right now, or my physical state. For example, I'm sitting. What's my physical state? My breathing. Where's my leg? Or what's going on? Some palpitation, okay? So paying attention to one's thought, emotion, physical state, or any other thing outside also is possible, but on purpose. We are clear that we are paying attention on purpose. And in the present moment, it's easy to think in this way. And one is the awareness thing, awareness in the present or something. And the other thing is when you have something registered, okay, when you are aware, how do you relate to that? For example, I have the thought, I might fall. I couldn't memorize something, then I have the rumination, I couldn't memorize yesterday. And I feel so bad about it because not being able to memorize is bad for me. So non-judgmental means, okay, I could not memorize, I have this thought. It comes, okay, as a thought. So neither trying to attach to it or trying to run away from it. Because so many things in the life we cannot solve. We have to simply be observant, but active observant. So, and to be on the safe side, I said, I'm presenting here just as a student of mindfulness. So I'm just using the script given in the Western book, okay? So it's more about mindfulness of breath, okay? Okay, so where is it? Okay. Okay, before we do this mindfulness, let's try to close our eyes. Or if you do not want to close your eyes, that's also okay. Try to focus somewhere where it is comfortable for you. Okay? Just try to bring in your mind what you have been thinking about in last few days. About your family, about your friends, about your health, anything. Or things which have been bothering you in last few days. Oh, he did like this to me. Come on, it's not fair. Oh, my child, blah, blah, blah. Or what about my exam? Oh, we're getting hungry. What time this presenter is going to finish? So try to bring whatever is bothering you in last few days. And you're doing this on purpose. Now, I invite you to go for another exercise where you can open your eyes. So, whatever we bring into our mind, that has some response in how we feel and how we behave. Now, we are trying to do some experiment where we are trying to focus our mind on a very neutral thing in our own brain, okay? So I again invite you for that, okay?
First three sessions, I'd like to welcome Professor Dr. Chandrakant and Mr. Jyotilal Das to please chair the sessions.
I work in an ENT hospital, purely ENT hospital, where lots of patients with tinnitus come to our OPD. And tinnitus has become a serious problem among the adults and even in young adults. So I was thinking to do intensive sound therapy in the patients. But before that, I thought why not to look into the patients to look into the immediate effect of masking in the patients. So this was a single session trial, and at current scenario, if you see, 10 to 25% of young population are suffering from some kind of tinnitus, and this is a huge problem among the adults. So coming to the point, tinnitus is a ringing or noise in the ears, one or both ears. At present, there is no known cause for this tinnitus, but it can be linked to the noise exposure, hearing loss, medications, and even mental health conditions, and apart from that, tumors, blood-related diseases, and so on. Similarly, there is no exact treatment for tinnitus. There are lots of approaches that can be done to reduce the symptom of tinnitus in patients, and those are counseling, hearing aids, and even tinnitus maskers. And in counseling, cognitive behavioral therapy to reduce the mental health condition, to improve the mental health condition like depression, anxiety, and hearing aids and counseling can be also an option. Tinnitus retraining therapy, sound therapies, and counseling by a counselor can be a good option for managing the tinnitus patient. Person-centered therapy. Patients are motivated positively and they are asked to cope up with the tinnitus and live a normal life. Tinnitus activities treatment includes the emotional state of the patients and hearing problems, sleep problems, and those related things we are going to counsel the patients. Next, hearing aid. Hearing aid is one of the best options till date. Whoever the patient is having a sensory neural type of hearing loss. And it is found that many studies have found that 85% of the patients have some improvement in their tinnitus level after using the hearing aids. So next option for tinnitus management is sound therapy and tinnitus maskers. And American Academy of Otolaryngology have also recommended the sound therapy techniques for tinnitus patients, and it is found that 83% of the population with tinnitus are improving with these techniques. But still, the exact evidence is not found. And being a audiologist, I think holistic approach is better in the management of tinnitus patients. Masking, hearing aids, and counseling. If we look into a holistic approach, this can be very much beneficial for the patient with tinnitus. And my study was very simple, and my aim was to look to see the immediate effect of masking using tones and noise in the patient with tinnitus. And within the duration of 5 months, I encountered 54 patients with tinnitus who came to visit me, and excluded participants were the patients who had conductive hearing loss, mixed hearing loss, hearing aid users, and were having mental related, psycho-related medicines and other therapeutic medicines were excluded from this study. Only the participants who were having intact tympanic membrane and a type of tympanogram and normal hearing and sensory neural type of hearing, they were included in this study. And my procedure for this study was also very simple, 3 steps only. Frequency matching followed by 3 alternate force choice method. Second one was loudness matching. It was dependent on loudness balancing. and third one was experimental trial, where 3 trials were given. The session was around 25 to 30 minutes, where 3 trials were provided. In those 3 trials, 5 minutes each trial, 2 minutes gap. So my end result was, depending on the 4 points, there was no change in the tinnitus level and slightly improvement in the tinnitus level, and tinnitus was almost inaudible and complete inaudible. So frequency matching was done. As we know that 3 distinct frequency were presented to the patients, and the frequency that was similar to the tinnitus level was selected, and it was again 3 frequencies were presented around those frequencies, and it was narrowed down to the best frequency that matched the tinnitus level. So result, total number of patients were 54, where 7 patients were excluded from the study who had intact type of tympanic membrane but had some kind of hearing loss. So total patients included in the study were 47. After frequency matching, we can see I only use narrow band noise, pure tone and variable tone. And most interestingly, I found that most of the tinnitus patient, the pure tone was the tone that matched with the patient's tinnitus. And on the other hand, more interestingly, higher frequency was found to be the most common matching frequencies in the tinnitus patient. The patient was asked about the feedbacks, everything. So this is the finding we can see. Interestingly, in normal to mild hearing loss, most of the patients had tinnitus, and more interestingly, we can see almost inaudible and complete inaudible, which is in the circle line. We can see that most of the patients were in those areas. So we can see that normal to mild hearing loss patient benefited from the masking with pure tones and noise, and their tinnitus level were almost inaudible and complete inaudible. And 19% showed that there was no change in tinnitus, and 13% showed that there was slight change in tinnitus level, whereas 40% patients showed almost inaudible and only 13% complete inaudible. Discussion point. Conclusion. I found that matching and masking tinnitus significantly reduces the tinnitus level. And if we use extended high frequency audiometer, it can be more effective. Thank you once again.
Thank you, Ashok.
I am Ajapa Nepal. I am a 3rd BSLP student at Aish Mysuru. Today I am here to present my study done on the topic Impact of Recreational Noise Exposure on Auditory Closure and Binaural Integration. This study was done keeping in mind the adverse effects of the high level of recreational noise exposure towards our auditory system. The few examples of our recreational noise exposure could be listening to music in our personal devices or attending parties, concerts or gigs. However, there remained a notable gap in our understanding of how recreational noise exposure impacts our auditory processing abilities, specifically our auditory closure abilities and interhemispheric processes like binaural integration. Therefore, the aim of the study was to evaluate and compare the auditory processing abilities like closure and binaural integration in people with and without the recreational noise exposure. The objective of my study was to compare the accuracy scores that we get from time-compressed speech test and the single correct and double correct scores that we get from DCV test. Now moving towards the method of the study, a standard group comparison was done using purposive sampling. There were 60 participants in total. We divided those 60 participants into control and experimental group using a recreational hearing habits questionnaire, also known as CHAR questionnaire. It is a recently given questionnaire by Lopez and Morales in 2014. After administering the questionnaire, we had 30 people in our control group with a normal audiological profile and 30 people in our experimental group with a normal audiological profile. This is the recreational hearing habits questionnaire or the CHAR questionnaire. These questions were embedded into Google Forms and was given to the subjects to self-administer on them.
After the questions were administered and after the subjects were segregated into 2 groups, we did 2 tests, DCV test and time compressed test. Dichotic consonant vowel test was done, where a degraded acoustic stimuli was given. Basically, monosyllables were given with 60% compression rate. The material used for DCV test was given by Asha Yatiraj in 1999, and for time compressed test, we compressed the monosyllables 60% using Pratt software. After the tests were done and the data was obtained, it was fed into Shapiro-Wilks test, which revealed that the data was not normally distributed and hence a non-parametric test had to be done. Mann-Whitney-U test was done, which revealed that there was no such difference found in DCV scores of the 2 populations. However, in time-compressed speech scores, the people with noise exposure, they performed poorly compared to the people without the noise exposure. This showed the poor auditory closure abilities in the individuals with high recreational noise exposure. It was also indicative of the selective impact of recreational noise in auditory processing. Processes that involved identifying distorted or missing acoustic signals seem to be more affected compared to DCV, which required us to combine the information presented to both the ears. Here, an additional thing that needs to be noted was extrinsic redundancy seemed to be lesser for time-compressed speech test than it was for DCV test. Concluding my study, the study highlighted the degrading effects of recreational noise exposure on auditory closure. It also emphasized the importance of mitigating recreational noise-related risk for auditory processing skills like speech processing in degraded conditions. The practical implication of my study would basically be to spread awareness amongst people with high recreational noise exposure and how it could affect their audition, which is apart from their peripheral hearing too. The awareness can be spread and the people can be counseled and they might be recommended to use preventive measures for the same. These were the references that I used for my study. Thank you.
And with your permission from respected chairpersons, I would like to introduce my topic. It's myths and misperceptions regarding hearing loss and use of hearing aids in average population. I take more time before and after the exact diagnostic test. That's why I should know how patients perceive about their hearing loss, ear care, and how they perceive about our rehabilitation, mainly hearing aid that we are using. So here, first point is, in 2-3 presentations we have already known that 464 million people are suffering from degenerative hearing loss. But the main point is, among them, 80% of those are from low and middle income countries, that is mainly maybe the South Asia. So here, those people might have their customs, beliefs, and their own perception about how they are taking care of their ear, and they feel like earwax is a waste product. It's not useful. It's a waste that we have to clean it properly or frequently. And another thing is how the people perceive about their hearing abilities. There is a stigma that they are considered as uninteresting, or they are cognitively impaired, or they can't understand, so I don't want to speak with them. There are a lot of stigmas within the people with the hearing loss and the people around them. So, and other thing is how the people perceive the people using hearing aids. That is also a part we wanted to see. So, as I mentioned, there might be a lot of misconceptions. Whatever the misconception that we are used for this study might be less. There are a lot, but still, what we did was we conducted a survey through Google Forms, and we 5 audiologists sat and then made 20 questions, and they advised me to separate those questions to 4 different subcategories. Perception about ear care, perception about hearing loss, and hearing aid. So we wanted to see how people perceive about these 3 categories. So the QR code is for the questions. If you want to see what are the questions we have used, you can scan it and see. So there were 431 responses, almost 42% male and 58% females. Interestingly, the mean overall correct response was only 10, so it was low in all the 20 questions. and we try to see and compare the result in different age groups, education levels and residential areas. In ear care, hearing loss and hearing aids, these are the tests we have used for the analysis. When we see about the ear care, the graduate people have more knowledge or they know more about how to take care of ear than the high school degree or the primary education level. Still, I want you all to remember that overall correct response was still low than what we expect. And even persistent across age, again, people age range from 20 to 40 years have significant scores than geriatrics and young adults. And across residential areas, there was no difference in urban or the rural settings. Same result for hearing loss also, where the graduate degree holders had more knowledge about how they take the hearing loss. And again, the same result for age categories, 20 to 40 years have more knowledge about it. And again, there was no difference in different residential areas, the knowledge about the hearing loss. Same for the hearing aids. I don't want to take more time. Again, the result is same. Okay, so why the geriatric and teenagers might have more lesser scores? Maybe the geriatrics have deep-seated customs and beliefs from previous generations or how they are being taught. And for teenagers, maybe they don't want to express that they have hearing loss or they have hearing problem. Maybe they are considered as like lower than their peer groups.
Unresponsiveness, catatonia. So this is quite important to highlight for the speech and language pathologists that this case is coming up. But we need not have to refer to a speech therapist because all of the cases, they reverted back to normal after the treatment. But there are some case reports where they say there are long-term speech impairment in the children with the anti-NMDI encephalitis. Apart from the secondary causes, there are some primary causes of speech language disorder in children. But even the primary causes of the speech language disorder in children, most of them have comorbidities. So that's why speech language disorder may be one of the earliest detectable symptoms of other underlying serious neurodevelopmental disorder. So almost all children with intellectual disability have some or other form of the speech and language problem or communicational skill impairment. So most of the comorbidities that occurs in the children with SLDs are, we know that autism spectrum disorder, attention deficit hyperactivity disorder, and learning disabilities. So that's why I'm highlighting children with speech and language disorder are at higher risk. Okay, they might be comorbidities, but the children without comorbidities also are at higher risk for later life for learning and psychiatric disorder. So that's why it is very important to carefully examine the speech and language skills in children with other neurodevelopmental disorder, as well as to identify other underlying neurodevelopmental disorder in children who present with speech and language problem. So then what do we do? So we all know management is multidisciplinary team with speech and language therapy. Okay, then for that we need to do the early identification for timely referral. So how do we do the early identification? We need the screening tools. So American Academy of Pediatrics recommends the development of developmental and behavior screening during the regular well-child visit, that is 9, 18 and 30 months. But the children, the kids who are admitted in the NICU, so the NICU graduates, they need more frequent visits. The first visit being within the first month of the discharge from the NICU. But we do not have a systematic follow-up program in our country. Similarly, so different institutes in our country are using different tools for screening. We do not have our standard and validated tool to screen the child, to screen the infant, to detect as early as possible. Similarly, this assessment, this developmental assessment should be done by the pediatrician. But unfortunately, the pediatricians are not well trained. So that's why we are not being able to pick up the children as early as possible.
We took a it was a cross-sectional study design, and for translation, what was done, like for this overall study, we did the questionnaire construction and then scoring the criteria and content validity of the constructed questionnaire. After that, pilot study was done, and we started with our first study in that particular questionnaire, that was administration of that questionnaire on parents of children with ASD, and to compare that in different severity. Find the perception of the parents' quality of life and the perception of how problematic the child's ASD features difficulties is making on the parents. So it has two parts. Gives us overall perception of their own quality of life, and it has 28 items which will be rated in 5-point Likert scale. And it varies from 1 is not at all to 5 is very much, that is not at all satisfied, to 5 is very much satisfied. That means higher values indicate the high quality of life. And part B, and in this also, in part A was there, we have psychological and physical health is also there. For 4 questions involve that factor. So what the original author has done is he has reversed the scoring. Because it will be like 5 will be not at all, the problem is not there, and 1 is the very much problem is there. So the scoring in overall 28 items will be same.
For that, he received surgical intervention, left hemorrhagic lectomy, left modified radical neck dissection, followed by reconstruction with free fibula flap, and he was also treated with radiotherapy a month after surgery. The assessments had to be conducted were cranial nerves examination, articulated system assessment including OPME, Canada Photo Diagnostic Articulation Test, DTK, and intelligibility rating. Friendly design 3 assessment scale, certain selected subscales of FTU were also used, and phonatory system was assessed using both perceptual and instrumental analysis were performed. Measure of severity of oropharyngeal dysphagia.
Over the years, dichotic listening have undergone several modifications. So one of the important modifications is including the forced recall to study the attention-based effect on speech laterality. So this was done by meticulously varying the instruction to either focus on right ear or focus on left ear. So several fMRI evidences have suggested that 3 different dichotic conditions test 3 different cognitive processes, that is lateralized perceptual process, that is bottom up for free recall, attention process for forced right, and executive function process for forced left. So I've introduced a new term, that is cognitive flexibility. So what is this? Is ability to shift the attention between 2 tasks. So when I'm doing 2 tasks simultaneously, how well you are able to shift the attention. So how do you study a cognitive flexibility? You do a task which has a most correlation with that of cognitive control. So dichotic listening in elderly individuals shows significant deviation in selective attention. So several studies have shown that the magnitude of ear differences increases as you age. So that is an indication of left ear deficit. So what is the research gap? Using dichotic listening, this cognitive flexibility has not been studied. So dichotic listening in elderly individuals have variable findings because of 2 schools of thought. So one say that no ear advantage, another say that left ear deficits, and also attention related cognitive control has not been studied in elderly individuals. So Mangalore study design was analytical cross-sectional. So the study was approved by research and ethical committee. So this had 2 group of populations. So one is middle-aged, one is elderly individuals, so 25 each. So these are the inclusion and exclusion criteria for group 1 and inclusion and exclusion criteria for group 2. So to collect the data, dichotic double word test in Canada developed by myself was used. So this was tested in 4 different conditions. So one is free recall, where the patient was instructed to concentrate on stimulus coming from both the ears. Forced attention right, where the subject was instructed to concentrate on the stimulus coming from the right ear, though it was a dichotic condition. And forced left was the opposite of that. The subject was instructed to concentrate on the left ear. So in switch attention, there was a beep stimulus presented, so which is an indication for a subject to which ear to be focused. So sometimes we used to come and right ear, so the subject has to recall from the right ear, and sometimes it came from the left ear and the subject had to focus on that. So coming to the results, so there was a significant group differences, so which indicated that elderly individual performed poorer in all the conditions, so when compared to normal adults. So within subject analysis showed that there was a significant ear difference in both the groups. Significantly questions the amplification to the left ear in elderly individuals. So that's an open question to be discussed and studied in the further experiments. So to summarize that, there was a significant ear advantage in normals. So that shows the clinical utility of this kind of dichotic test in assessing adults, because you don't have that many dichotic tests in adults, so because always you have a ceiling effect that is seen in adults, so because of that you are not able to identify the ear asymmetry. So this is, we use double word test to make it more complex, so the clinical utility of this kind of test is more. So again, it was successful in identifying deficits in elderly individuals, so that again validates the clinical utility of such kind of tests. So these are the references. Thank you.
So this is about high risk register. We know that in the newborn hearing screening, we always, the first step is to do the high risk register and classify the baby as whether the baby has high risk indicators or no high risk indicators. Now, way back in about 2 years back, when I first joined Department of POCD, there was a HRR being used, and that was very different from what actually was recommended by JCIH. And if I actually, when I dwelt into it, I realized that earlier what we used to take as case history in the speech pathology department and the audiology department, whatever risk factors used to be there in that case history, that were actually translated as HRR, and there was no scientific basis for that. So we actually took up a huge project where we thought, we will build scientific basis for the high risk indicators that we have listed in the HRR. And one of the high risk indicators that we have in that HRR is the hypertension of mothers during pregnancy. So here we are to present the estimation of risk of hearing loss in infants born to mothers with hypertension during pregnancy. So we know the diagnosis of hypertension, that is, if the systolic pressure is more than 140 and diastolic pressure is more than 90, we tend to diagnose them as persons with hypertension. And it can happen during the early periods of pregnancy, or it can happen in the later periods of pregnancy. Basically, the hypertension is known to affect the microcirculation and the possible immunologic pathogenesis and can induce damage to the inner hair cells. So that is the hypothesis behind hypertension causing congenital hearing loss. So the need of the study is to understand the potential risk of hearing loss in infants born to mothers with high BP during pregnancy. So the aim is to provide a valuable insight into the correlation between maternal chronic hypertension during pregnancy and hearing loss. We used a standard group comparison method where we had a group of mothers who had hypertension during pregnancy and the other group of mothers who did not have hypertension during pregnancy, and this was the only risk indicator, okay, only differentiating factor. There were no other risk indicators. So there were about 1,030 mothers who did not have, that was the control group, who did not have any hypertension during pregnancy. Similarly, there were about 347 mothers who had hypertension during pregnancy. If the first screening showed refer, then we did rescreening, and in the second screening also, if there was refer, then we did diagnostic evaluation. So this is the standardized protocol that we use at AISH, and this we have talked in detail yesterday in the panel discussion also, so I'm not going to detail because of time constraint. So in the results, when we did the first screening, we found that of the 1,030 control group, we found 16 were referred in the first screening. That's about 1.5%. On the other hand, in the clinical group, where the mothers had hypertension, 50 of them were referred in the first screening. We did the second screening, of the individuals who were at risk in the first screening, and we found that among the control group, only 4 were referred for diagnostic evaluation, and among the clinical group, 11 were referred for diagnostic evaluation. Whereas among the clinical group, that is when the mothers had hypertension, 7 out of 347, which is about 2.02, turned out to be having hearing loss.
So this is just a framework of a study. I have depicted this in a form of a case study. So first, developmental speech sound disorder. So this case study is about speech sound disorder. It's usually categorized by the difficulties in acquisition, production and perception of speech. Not only in the, not only just regarding the oral motor things, but even beyond that. And these things, when there is difficulty in acquisition, production, perception, it results in the errors of pronunciation. So that ultimately limits the participation. We have the ICF goals there. Like they're outside, when these are outside the limits of normal variation, so they may significantly impair the participation, communication, and all the other aspects of why communication is important. So this will result in the reduced intelligibility and significantly affect communication and definitely to all other aspects. So that's why it's necessary to identify in a very reliable way and comprehensively assess the phonological skills to direct towards early intervention. Yes, we have been into early intervention so much. Even it's important, early intervention is even important for SST case. So for that, we need to identify the types of errors, just like Madam discussed yesterday, what the syllable shapes, all the domains are there. So because of the lacks of tools to assess articulatory and phonological skills in Nepali population, like a proper tool which has a norm, from which we can quantify, because of this, yes, a lot of times we are not able to identify this in the Nepali population. So especially when we have to do independent or even relational analysis, it's been difficult in Nepali population. That's why it's important to develop a framework to assess significant domains. And now this case study, it highlights the assessment of phonological skills of a native Nepali speaking children with speech sound disorder. It just depicts, this is a case study. So the aim of this case study is to assess and document the phonological skills of a 4-year-old native Nepali speaking child with speech sound disorder. So we have developed the discrete objectives as well, and to assess the speech sound disorders, speech sound errors, to assess the inconsistency and the variability. The child is a native Nepali speaker. So how we develop the stimulus is, first we develop a set of words that encompasses the phonemes, consonants, vowels, and even clusters in all the positions. We validated that. We did the content validation by 2 SLPs, and we formed the pictures for that. For each word was depicted as a picture, and again the picture validity was also done. And in this way, we developed our picture stimuli for the assessment, for the comprehensive assessment of this. Similarly, for the connected speech test, we chose the sentence imitation task of a very popular story of Thirsty Crow, and we hired an artist to draw the pictures and validated that. That way we formed picture stimuli, and we used a laptop computer system with the Zoom H1 stereo recorder for recording and storage and data analysis.
Today we have a very interesting topic to discuss in the panel, the decision making. And often we come across different situations in life where we have to make decisions. And what we are absolutely based on the decisions what we make. So sometimes we make the right decision, sometimes we make the decision right. So now, especially in respect to science, the clinical science where we work, we come across different situations in life, clinical questions, which pose so much of questions for us to make decision for patients and also for us. Now today I have selected two important topics for discussion on decision making. This is keeping in mind this country Nepal. This country Nepal has recently announced a cochlear implant program where irrespective of the age, gender, or the cochlear implant is provided 50% concession. So whereas in India we have a cap on the age, but in Nepal there is no cap on the age. Irrespective of whether it's a pediatric or geriatric or adult, they can undergo an implant, and 50% is funded by the government, remaining 50% has been funded by the patients. So which means there's so much of responsibility on the shoulders of the audiologist, otologist, speech language pathologist, and all the decision makers in a cochlear implant field. So my first discussion is about this particular scenario where you have a normal hearing on one ear and profound hearing loss on the other side, or otherwise we call this condition as a single-sided deafness, right? And we all know the advantages of binaural hearing and monaural hearing. So in binaural hearing, you have advantage of understanding speech in a complex environment, sound localization, and other cues, which helps in better hearing life science experience. In single-sided deafness, I think the patients have difficulty to understand speech in a noisy environment. They have difficulty understand speech in a very bad room acoustics, and localization of sound is all a major issue. And cochlear implants in single-sided deafness is not new. So we've been doing cochlear implants for single-sided deafness almost for 15 years, and there were a lot of publication. The first single-sided deafness cochlear implant was performed in the year 2000, and for almost 20-23 years, people have been receiving cochlear implants in single-sided deafness. Now the question here is, and there are multiple options. What are the other options apart from cochlear implant? You have cross hearing aids, you have bone conduction implants, you also have a cochlear implant. These are three options are also left now. Now the question now is, which is the right decision to take and to who is the most important question. Now, even in India, the single-sided deafness is self-funded program, it's not funded by the state. Now making decisions, we have very similar challenges with respect to India or Nepal. The challenges are quite similar. So this is one of the important area to discuss and to make decision on who is a candidate for a cochlear implant, who is a candidate for a cross, or who is a candidate for a bone conduction implant, and on what basis we are going to make decisions. So let's start from here. So let's take opinion from a common opinion. Would you implant or would you suggest an implant for a patient with single-sided deafness? We'll start from Chandrakant.
Thank you. Of course, I would consider implantation in single-sided deafness provided I know the duration of deafness. So if it is like long-standing duration of deafness, then I would rather go with bone conduction solution compared to cochlear implant, because that side of auditory pathway hasn't been used for ages. Other thing is, when I do talk about the choice of device, I counsel about different devices to my client, and I tell that if you want the true binaural hearing, then cochlear implant is the solution. But if you want to hear from this side, then you can go with the bone conduction solution or the cross. So these are the things.
So in principle, your decision is based on the duration of deafness.
Duration of deafness and from where they want to hear. They want to hear from the side, or they want to hear from that ear itself.
So you'll ask them to make a decision.
No, I explain them and I tell that okay, the duration is less, so better we should go with the cochlear implant.
So your decision is to go for cochlear implant.
Yes, with the durations.
Yes, sir.
Actually, we face quite frequently see the patient with a single-sided deafness. So far, maybe several thousand people have seen, and none of them have agreed for the cochlear implant surgery. So always I give priority to the patient. I give advice, but decision making is I leave on their hand. I have given option for the cochlear implant, first choice, Second choice I have given the cross hearing aid. That also they do. For the third,
Do you know why they don't go for
yeah, because of the cost factor.
Cost factor.
Yeah.
That's precisely why I want to put up this specific discussion, because in India it's 100% self-funded. At least in Nepal there's someone to give 50% of the cost. So given that situation, do you think that people would go for a cochlear implant in single-sided deafness case?
No, even though it is we are giving not 50%, we are providing 6 lakhs rupees for the device. Only 6 lakhs of the currency.
That's quite
device and 50,000 for the habitation, which is not payment 50%. So, and all of them, those who want to go under surgery, they want 203. So that is more expensive again.
No, but do you think, what is one reason why they don't want to go for a cochlear implant despite the 6 lakhs money is being funded?
So first of all, they are worried for the surgery. The weight test.
Surgery was one of the major things. You, sir?
What Congress said, that is true. But that depends on the cosmetic appeal. They don't want to use either hearing aid or cochlear implant. I used to ask the patient, no, I don't have problem. Just I came from the beginning. Like I had one incident. One child came to know he has a hearing loss in 1 year when that child was swimming. He said after swimming somebody came and he spoke on the other side, hearing loss side, then he understood I am not hearing. That kind of, because till that time he was not knowing that. The most of people say, no, why I want to use hearing.
So your thing is basically they don't want to go for any device simply that they will be projected as their handicap.
Yeah.
Like they don't want to project their handicap.
Correct.
So they
unless like a journalist.
Okay. And at what age, Shufali, at what age do you pick up single-sided deafness?
So depending on.
I'm talking about the pediatric.
Yeah, pediatric population. So if you look at a regular CI, right, so we say 2-4 years and all, but if you look at studies, when you have auditory pathway which has already been developed, so we do not, the 2 years is not a capping for us, we can go beyond, we can think of 5 and 6 years as well. And even after 5 and 6 years...
You mean to say 2 years and 5 years from the time you detect deafness
from birth? From birth.
My question is, at what age?
From the time you detect.
We detect that the child has got a deafness on one side.
I think right then and there, if it is very young children who is 3 months, 6 months, then you can wait for 3 years.
But in our opinion, I think we usually see children around the age of 7.
Okay.
So around 6 to 8 is the age where we pick up children with SSDs, because unless otherwise you have a newborn screening program, or even sometimes late onset of single-sided deafness is a problem. And what do you think is some of the etiologies for SSDs?
Hello. I just want to add one point of Dr. Ranjit. Around the device selection in my patient which we see, I'll go for cochlear implant for this.
Okay.
And I just want to add on to what Karnatha and Kaviraj sir added. It depends on the age, I think. If a single-sided deafness patient, an adult patient, work-wise, and is a banker, suppose say, who needs the requirement or the need of bilateral hearing is also important. But the first is again the cost factor, because even 6.6 lakhs or 6.5 lakh and paying for the other year when the other year is normal, they deny. So it's the cost.
And given a situation where the implant is given free, the surgery is free, rehab is free.
I think the majority of the people will go for it.
Are you sure?
Yeah, I think so. Apart from the cosmetic part and the need of the patient, like if it's an elderly patient who is homebound, they don't usually go for it because it's cosmetic. The battery changes has to be done frequently. But if it's a middle-aged, work-wise, is very active, then I think the advantage of binaural hearing is much more. So they would.
And now you might have seen a lot of children with SSDs. Not much.
Not much.
Okay, fine. So no, with few patients whom we have seen with SSDs, now we have seen patients with hypoplastic nerve on one side, or absent eighth nerve. So almost 10% of the patients with SSDs are anomaly, or the cochlear anomaly, which is absolutely missed out because we don't do radiological imaging unless and otherwise we detect some kind of hearing loss of that. So it goes unnoticed for that. So, yes, sir, you want to add something?
Besides of the scaring for the surgery, major factor आता है फिर ये other cost factor. and
keep it closer.
Cost factor was a major reason. So as Dr. Sandeep yesterday mentioned, people have got tendency of free help seeking behavior, something like that. So मुफ्त में मिलेगा तो अलकतरा भी पिएंगे. If they get in free, they can drink coal tar also.
Okay.
So if they get in free, certainly they'll go under surgery. All this fear will go off.
Okay. Anup.
Recently, a few years back, I had experience with one patient with a single-side deafness, female with background of engineering background. While working in office, she had problem in communicating with the colleagues. When she came, then we counseled about cochlear implant and all the solution because of, as already Shan have mentioned, because of cosmetic options, she doesn't want to go for the surgical options. Then we suggested bone conduction with the eyeglass solution. She was doing good, but some of the time due to the issues with the feedback and all, she was not so happy. So obviously, I think for single-sided deafness, it is challenging from the aspect of patient also, from aspect of counseling also.
So, since cost is one of the major reasons, so how many of your patients agree for a bone conduction hearing aid or a cross, because that's substantially much cheaper than cochlear implant?
So out of so many, I think in Delhi, after COVID, we are getting so many patients because they found during that time. So out of that, only one have tried for trial.
Where do you think is, what are we missing out here? See, one end, it's a cost. Now, fine, it's agreed because they have to fund. Another one is you have a device which is not that expensive. You can have a bone conduction hearing aids or a cross hearing aid, which is not that expensive than an implant. So now, despite having the technology which is less expensive, and also having the technology which is more expensive, what is the percentage of people with single-sided deafness accept the device, whether it's a low-tech or a high-tech? Now, in my opinion, I think it's very, very minuscule. 1 out of 50 patients would even accept a device, I think. Now, the question is, what are we missing here? Why they're not able to accept? One is, you said cost, that's leaving. Another one is social stigma. Now, what do you think we need to do to overcome this? But do you all believe that 2 years are more important or better than 1 year, right? So as a scientist, you believe everybody should give it 2 years. So what do you think we should do to provide restored hearing on the deaf side, and especially in SSD patients?
I think first and foremost, we need to accept the fact that CI is helpful for patients with SSD. Because you know what happens, a patient goes to 5 different clinics and hears 5 different opinions. So if you look at the articles, if you look at the patients now, you know, it is possible to get closest to natural hearing. And when we are convinced that yes, it is the right solution and yes, they need to go for that, and when we say this in that confidence to the patient, that's when they'll definitely, or say majority.
Perfect. So you want awareness and education is more important among the professionals first, right? Among the medical professionals and the allied medical professionals, they should know this is the right way forward, restoring hearing for them. And then the educating the public, awareness is more important. So, so you need to write more about SSDs, restoring hearing in your articles, television talks, advertisements, signboards. Education is important because you want to add something.
And one more thing is, like, as a professional, even we should be educated, like what is the benefit of having cochlear implant.
Exactly, that's what education within the professionals and also to the
just we can tell them about the data, single-sided deafness, what are the benefit the earlier users they got, so that we can put those data.
So the different ways of educating them.
Yeah, educating them.
So you want to add something? One question to you also, finally. When you spoke about the duration of deafness, what is the optimal duration of deafness that you would prefer to go for a CI?
See, if it is below 7 years or 10 years at the most.
From the onset of deafness?
Yes, onset of deafness. I'll prefer CI. On the contrary, we have done cochlear implant for 30 years of deafness also, and the person is doing good. But the general consensus is lesser the duration, CI is preferable choice. Here I would like to tell about my experience with one of my clients who was at the age of 15 when he came for a free hearing camp what we organized in our clinic, and he had single-sided deafness. We didn't know since when, so we assumed like, okay, it is since the birth. Okay, so we offered that time BAHA, because BAHA was available at that time. There was no bone conduction solution from Medel, and he refused. He said, no, I'm doing perfectly fine with 1 year. At the age of 25, he again came with sudden sensory neural deafness on the better ear. And then it was like, we were in like fix what to do. Had we given BAHA that time, that BAHA wouldn't have been of any use. Okay, but had we given a choice of implant that time, then at least 1 year is working now, right? So the story doesn't end here. So we told, okay, we'll try different medication, all steroids and all hyperbaric oxygen therapy. And we were waiting like, okay, if there is any recovery in the sudden sensory neural deafness ear. He didn't have patience, he had money, so he flew to another city, one of the best centers, and he got operated, unfortunately, in the previously deafened ear. And the results, what he expected from cochlear implants, were not up to his match or expectation, what he thought of. And finally, after roaming here and there in the city for therapy and all, again someone brought him to us, and we said like, okay, fine, you have gone, no problem. But if I have to give a choice of cochlear implant, I would go for the recently deafened ear, not the previously deafened ear. And he got implanted again on the recently deafened ear. He's doing fantastic, and he's not using the other implant.
Yes, see, what we do is, we also have similar experience, because we don't have innate data, convincing data to substantiate what is the optimal duration of deafness for you to make a choice. So what we have looked at our data, we have a lot of children, those who are implanted with cochlear implant, unilateral implant, by the age of 1 year, 1.5 years. Right? So they are similar to single-sided deafness. So they hear with only one side, not with the other side. And later, when they have more money, or maybe by the age of 12, 13, 14, they come and ask for a contralateral implant on the contralateral side. Now, one because they read somewhere, another one because company is pushing too much of marketing to some of them, so they wanted to get the implant on the other side. So if you look at the children whom we have done a sequential bilateral implant, where the implant is done, the second implant is done after the first implant, not at the same time. Any child, even if the first implant was done at the age of 1 year, if the deprivation of the hearing on the contralateral side is more than 7 years, they don't like to wear the implant on this side. They reject. They don't like to wear it. Because the quality of hearing that with the first implant was much better, simply because of the neural plasticity. Now, at 7 years later, you give another implant to them. They don't accept it. They don't like it. They don't like the quality of sound. They can go to school without this device, but they will not go to school without this device. If this device goes on repair, they don't care about it for waiting time, but this device is good. So, based on this experience, looking at our data, we decided any child or anybody, adult, if the duration of deafness is more than 7 years, okay, we don't recommend them a cochlear implant. Despite we recommend, or despite they want to go for a cochlear implant, we give them an expectations very, very realistic current outcomes. That's one. Thank you. On the other side, you highlighted about the hearing with bone conduction device or the cross hearing aids. But the only thing is, the quality of sound or the benefit from the bone conduction device or the cross hearing aid is as good as the residual hearing on the better side. If the residual hearing on the better side starts going down, the quality suffers. Not because the device is not functioning, because you're dependent on one side. Another thing is, when you do a cross or a bone conduction device, you're still, it's monaural or pseudo-monaural or pseudo-binaural. It is not a binaural hearing. You are not restoring hearing on the deaf side. When you put a cochlear implant, the hearing on the deaf side is restored. Hearing is restored on this side. But when you use a cross or a bone conduction, you are not restoring hearing on this side. You will still have a problem of sound localization, speech performance, and noise. Everything will still be a problem. The only advantage is you overcome the head shadow effect. That's in a very specific situations, actually. Right? So, what we conclude from this discussion is, you all agree, cochlear implant is the best solution for single-sided deafness, provided, the cost is not a factor, the stigma is not a factor, and to overcome all this factor, education is more important among the professionals and also to the public. And even if you recommend a bone conduction device or a cross device, you will counsel them that it is going to be as good as the residual hearing on the other side. If the residual hearing goes down, it will suffer. And other important point is, sometimes you have patients with single-sided deafness with a fluctuating hearing loss. Actually, you can't classify them as a single-sided deafness also. Single-sided deafness is normal hearing on one side. Sometimes you have patients with autoimmune disorders, they have a fluctuating hearing loss. In those conditions, we straight away tell them go for a cochlear implant because at least 1 year you have a dependable hearing. And this side is not a dependable hearing. Okay. Right. So we will go to, sir.
Okay. Recently, we have done last year only sequential implant, bilateral implant, after the gap of 12 years. We are very doubtful whether it will be beneficial or we should go or not. We consulted so many people, experts from India also. They told we can go. I gave a trial of hearing aid in non-implanted ear, and he didn't like it. Then I told him not to go. I was hesitating. But later on again they came to me that I want implanted this year. And after 12 years, when the surgery has been done, both of them are enjoying that. They are very much happy. So 12 years gap is also to be considered.
But sir was there, I think one patient, two patients, one patient and what I am supporting you. What he said, I am not using this implant in the school time, but I am using only home. Then I said, you are doing wrong thing. Then you have to put off another implant and you have to use it at home. Then now he is
initial phase. After phase they are enjoying.
They are in. Now they are in.
Initial phase.
So basically, it's a case to when it comes to duration of deafness, it's a case by case decision. Okay, now let's look at the cochlea. Now this is normal patented cochlea. You have 2, 3 by 4 turns, excellent intrascalar septum, auditory nerve, internal acoustic matrix is normal, auditory nerve is present, vestibular and the semicentral canal is all well developed, and you can distinguish all these features in your CT scan and MRI as well. And we quite often get patients with anomalies. Anomalies of the cochlea, different types of anomalies, IP1, IP2, IP3, common cavity. And we also have patients with hypoplastic nerve. So you have, this is normal nerve, cross section, you have the facial nerve, superior vestibular nerve, inferior vestibular nerve, and this is a cochlear nerve. And you see in this image, the cochlear nerve is absent or hypoplastic. In this case, very thin cochlear nerve. It measures less than 2 millimeters or 2.5 millimeters. Now, and you can also have patients with hypoplastic unilateral hypoplastic. Okay. Unilateral hypoplastic nerve. You see the nerve is very well developed, thick on one side, and the nerve is very thin on the other side. Right. It's also possible. Now we are in the situation to design a cochlear implant for these patients. How are we going to go about it? And we all know that ABI is not a straightforward solution. People may say when you have an absent cochlea, absent nerve, hypoplastic nerve, go for a brainstem implant. That's not a straightforward solution. This is one of the classification by Senator where he said definite indicators when cochlea and the cochlear nerve are absent, then you go for ABI. In case if you have a patient with hypoplastic cochlea, common cavity with IP, common cavity with IP1 with the nerve being absent, presence of unbranched cochlear vestibular nerve or hypoplastic cochlear nerve, ABI is not a straightforward indication. right? So you have to try cochlear implant, then go for ABI. Okay. Now, this is just a indication based on scenario, not necessarily you have to follow. It can be case by case basis, right? So how are you going to decide in your practice when a patient comes to you and the patient is willing to pay for a cochlear implant, and how are you going to decide? One, how are you going to assess them? Now, how do you decide which choice of implant, which side you would use it, and in case when you have a patient who undergoes cochlear implant and when the performance is not good, when would you decide on what evidence that you would decide, yes, this patient needs to be crossover to ABI? Okay, so this is what we're going to discuss, and this is the last case that we will present. So let me start with Dr. Pabina. So I hope you might have seen a lot of patients with anomalies, right?
Yes.
So what do you think? What comes to your mind first when you see a patient with anomaly?
It's a very tricky zone to tell the patient about the outcome of the CI, and even to decide whether we really want to go for CI or not. So when we assess the patient, we usually go for MRI first, assess the patient. If there are any associated other anomalies are not there or not, patient may be...
No,
yeah.
I'll interrupt here. So when you say MRI, do you have any specific strength that would give you more information?
Not in...
So you're okay with 1.5 Tesla, or you want 3 Tesla?
Of course 3 Tesla, if it is available, but we don't have. So MRI first, and then I wish, as we were trained in Murph, CEP facility was there or not. And another is like, if Sefali and all are able to train us, like what about autoplan? I think that gives a better option for planning the patients.
So in assessment that you would think about a better imaging, so you would choose to go for a 3 Tesla MRI rather than 1.5 Tesla if they have.
Exactly.
And then you would assess other audiological investigations.
Right.
So audiological, then we can just go to the audiologist.
Exactly. Exactly. That's the
So
main...
Chandrika, so how would you assess audiologically to make a decision whether this patient needs a cochlear implant or a brain stem implant?
Right. So as you know, like I have my own private practice, not blessed with the institute setup where I have a lot of electrophysiological instrument. So primarily for the pediatric group, it's we rely on the behavioral response, aided response. So we give the hearing aid, we fit the hearing aid, and we call them for the rigorous AVT therapy. And in that we try to assess whether the child is getting any benefit with the hearing aid, the superpower, ultra power, whatever hearing aid we have fitted with. Another thing what I have learned with one of us, our friend, like we can do aided ASSR. So that I'm doing nowadays. So I do the aided ASSR with the hearing aid, and I try to see whether there are responses or not, and if the responses are repeatable or not. So that gives me some amount of confidence. And of course, we are blessed to have 3 Tesla MRI in our city. So now our practice has shifted to doing 3 Tesla MRI for all implantable candidates, like those who want to go for implants. Given the choice, if I have instruments to do higher electrophysiological tests like EAB and all those things, cortical, so then yes, that will add to the choice of whether to go with implant or not. But of course,
So your strong advocacy is like behavioral responses. So even if they're young, hearing aid, wait for some time, look for the responses, and then you make a decision whether to go for a CI or an ABI.
So just quoting one of the example, like I had a child who was 2 years that time, and we fitted him with hearing aid, and when he went to MRI, that time we had 1.5 Tesla available, so it was hypoplastic, and the decision was whether to implant or not, and which side to implant. Both sides were hypoplastic. So it was like to make judgment which side. So we gave the hearing aid, and we therapy was done, and we did all the tests, whatever we can. We even did the video recording, and we implanted him. So after implant, he is doing at awareness level. So there is awareness of sound, but he is not doing finer discrimination. Gross discrimination is there, finer is not there. So ultimately the child has landed up in total communication. So this is one of the case. On the contrary, I have another set of clients where they had hypoplastic and they are doing very well like normal cochlear implantees. So the results vary.
Okay. Yeah, sure.
I think in such kind of cases, transtympanic EAPR is very good at not only identifying the outcome but also deciding which ear to go for. If you want to go for right or you're going to go to left. And secondarily, nowadays we're also using autoplan to find exactly not only the thickness, but if at all the nerve is innervating properly or not. Sometimes you see the nerve, you see the innervation, but when you do a 3D reconstruction, what you see is it ends right before modulus. So it is not innervating. So even if you implant to a CI, you're not going to get an outcome. So API is what would be recommended.
And what kind of image you want for a autoplan? So you want 1.5 Tesla is okay, or you want a 3 Tesla?
More the merrier kind, so 3 Tesla if possible. And of course, if it is a CT scan, less than 0.6 mm of slice thickness, because that's when we can reconstruct automatic. If not, then we'll have to do it manually. But better the imaging, of course, we'll be able to identify even a very thin innervations if it is going towards vestibular side or the cochlear side, all that clearly.
Yeah, so the message here is 3 Tesla MRI is optimal and the best. And if you want to look at the CT scan slices, it should be less than 6 mm or 5 mm. Sorry, 0.6 or 0.5 mm is good for you to look into it. Now, coming back to you, with respect to the choice of the device, right? Now, how would you decide the device in a patient with cochlear anomaly? First, let's talk about cochlear anomaly.
Well, so cochlear anomaly, it we varies if it's just mild labyrinthine dysfunction, or say excessive gushers we're planning, or then it's a normal implanted device. But if it's a case of a greater anomaly, first the decision is whether to do or not, whether to go for implant or not. And if you are given the choices, the recent all the hybrid and all kinds of recent devices that we use, if it's available to us. But my basic principle is whether we go for we have not done till now, for greater anomalies we have not done. So my experience is pretty not so good in this. So we want to hear from
Dr. Karna. Yeah. Time up? Okay, 2 minutes we'll finish. Do you have any, how do you choose the device? Is there any preference for you?
We don't have much experience with the cochlear anomalies. Okay, so I haven't done set up. But we select usually, we do mainly metal implant. And then we have got choice. We select horn electrodes, most of them.
But how do you choose the...
But we are taking help from them. Measure the cochlear length and other things. What of them we are setting it.
So the trick here is, I think, the choice of right electrodes, because we know that we are not going to have a lot of spiral ganglion cells. So suppose if you're expecting there is going to be gaucher, go for form series. If you're then even in form series, we have to choose the right electrode. We have to do an autoplan. We have to make sure that we cover the entire auditory nerve fibers, whatever is present, so that we can give the possibility of best benefit to this.
And quickly answer the last question also, because you are from rehab. Someone asked this question. So how do you decide, when would you decide the child you will cross over from cochlear implant to ABI?
It's actually a very difficult question, because I know 50% of the professional will agree with me and 50% won't. But first thing is that we need to understand when are we expected to have certain milestones. Say awareness. If everything is normal in a patient with cochlear implants, 1 week the patient should have awareness. And discrimination is a conceptual task. In 1 to 3 months we need to have identification, right? So say mapping is, in these cases, of course, it might take a couple of more weeks, to figure out what is the right map, what is the right, say, thick duration of stimuli. But say somebody, it's been already 3 months, and it's been already, say, 3 to 6 months, and you do not have any awareness at all, okay, be it for loud sounds, no APR, no objective responses, then you know that this person needs to move to ABI, and that is with respect to awareness. And let's say identification. Again, identification, we have a criteria of 1 month to 3 months. Now we know that, if within this criteria, if he or she is not able to attain the identification, we again change the map levels, see the parameters change, and follow it up for a few more months, and say in 6 months to 1 year, again no identification at all, it's only awareness present, then of course we need to decide that this patient has to go for API.
Okay. Thank you. So just to sum up, the reason why I wanted to specifically discuss about this particular issue is now 15% of bilateral congenital hearing loss patients have anomalies. We miss them. It's quite high. Right? And what is more important is, the idea is to, now if you look at the success of a cochlear implant depends on the availability of the spinal ganglion cells. If there are no spinal ganglion cells, if there is no nerve, cochlear implant is useless. Right? Most important is you need to assess the spinal ganglion cell population, which is very difficult in these cases. So what we understand is, this is just based on some references, the spinal ganglion cells are present. For example, if you look at the common cavity, spinal ganglion cells are present on the lateral wall. At the same time, because there is a common cavity and there is a connection to the subarachnoid space, there is a possibility of meningitis if you don't handle it properly. An electrode can go into the internal acoustic meatus. We've got 4 patients in common cavity where 3 electrodes are in the internal acoustic meatus, communicating with the brain. So, choice of the electrodes. If you have an electrode of different length, then you can choose based on the size of the cochlea, shape of the cochlea, and structure of the cochlea. You can choose the appropriate electrode to give optimal stimulation to stimulate all the spinal ganglion cells, number 1. Number 2, it is sufficient enough that it doesn't cause much damage. It doesn't go into the vestibular nor go into the internal acoustic meatus. And most importantly, in a patient with hypoplastic nerve, we really don't know. The nerve is very thin. In hypoplastic nerve, the nerve is very thin. So the neurons may be anywhere in the cochlea. So you may have more neurons in the base and more neurons in the apex, but in the middle tongue you may not have any neurons. So it is advisable to stimulate the entire cochlea, so that even if there is some neurons left out somewhere, it's getting triggered. Okay. So number 1 is watch out. Anomalies are quite common. CT scan, MRI, radiological imaging is important, preferably 3 Tesla. CT scan 0.6 mm cut. And audiological investigation, if you have an electric ABR, that's one of the best choice to choose whether for CI or ABI, and also choose which side you need to do. If not, do the behavioral methods. When you decided for an implant, choose the appropriate electrode based on the auto plan, measure the length of the cochlea, size of the cochlea, duct of the cochlea, choose the electrode and do it. And after doing a cochlear implant, if the patient's performance is not satisfactory, then you go for an ABI. In my opinion, if the patient is hearing with an implant, I will not go for ABI. I don't worry about how good he is performing. If he is hearing, good. Because if you look at the outcomes of the ABI, there is also a possibility even with the ABI you will not get any benefit. There is no guarantee on it. Okay, if you can provide it, if you scan the brainstem, if the cochlear brainstem is well developed, we would think. Otherwise, we don't even go for an ABI if the child is just hearing. If the child is not hearing anything, no auditory sensation, then you go for an ABI. Okay, so thank you very much. And I thank the organizers for this opportunity. I think the lunch is ready. We go for lunch. Thanks.